Megan Fox.
And Megan Fox has the story.
Megan Fox.
Megan Fox.
Megan Fox writes at PJ Media.
Eat Tucker.
And that was your last.
Damn it, man. I cried for 2 days.
Megan, thank you very much for that.
So, I can explain the bed thing.
If you don't show up and vote, up your ass. I don't care if you're in the hospital. Crawl to the stake. Crawl there.
It's like Jesus going into the temple. He's like, I got a whip. Get out! Get out! The lovely and wonderful Megan Fox. Not that one.
Not that one. Not the weird one that drinks blood in his toe thumbs.
Megan Fox.
Megan. And honestly, Megan, if you don't like it, I'm sorry.
She's the devil.
Megan.
Megan Fox.
Megan.
Megan.
Megan Fox.
I've been very nice to you, although I could probably maybe not be based on the way you have treated me, but I wouldn't do that.
You've never met a like me. You want to tangle? You want to go? Holy sh**.
Too much cussing on this. I guess we didn't bleep it, so we got to turn it off. But it's.
You pissed off the wrong woman.
Oh my God! I have been assaulted, but Megan Fox runs wild on you, brother.
She's the devil.
Not for publication.
The story.
I'm Megan.
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 Megan Fox.
Thank
Thank you. Cheers.
Hey everybody, what's up? I'm back. It's Megan Fox. Every time I see that clip of me and Nick laughing our asses off over David Shane's threat letter to me, I laugh out loud. God, that was funny. That was a funny show. If you have time to go back and watch the Ricada Laws show with me reading David Shane's threat letter to sue me, that is a great show. It is worth a rewatch. It is so funny. And every time that I see that clip of him reading the not for publication notice at the top of it as we read it for publication, I laugh out loud. Oh God, that was a good show. Good times, good times. I miss Nick. Nick, I miss you. We should do something soon. But he's so busy, whatever the hell else he's doing. All right. I want to watch from yesterday Dr. Kirkpatrick's testimony. Now, in the Maya trial, let me get the banner going. So those of you who aren't familiar, make sure that you hit that like button, by the way, if you're in here. We are broadcasting live right now on YouTube, Facebook, and Rumble. I am not broadcasting on Locals today because Locals has a 3-hour time limit, and we usually go over it and it cuts off. So I opened up a live chat there instead. Don't tell me that StreamYard is starting to freeze my channel already. Really, StreamYard? Are we really doing this right now? Why am I frozen? Hold on a second. Hang on. If I back out of here, shit. I think you can still hear me, but StreamYard's going to do this thing. So if I disappear, I'll be right back. I'm just going to reboot and come back. I hate it that StreamYard keeps doing this to me. Hate it. I'll be right back, folks. And we're back. Okay. God dang. I don't know if it's StreamYard or I don't know if it's my computer, but I'm still having struggles. Let's hope that it doesn't happen again. All right. All right, here we go. All right, I got to open up the trial. Okay, so I watched a little bit of Law and Lumber yesterday of his recap of this. So he didn't play the entire testimony. We will play the entire testimony here on a little bit higher speed. But Rob's comments were really funny. I mean, I agreed with him totally. Dr. Kirkpatrick is a total character. Reining him in is absolutely impossible. Oh, hang on. Now I've got someone's calling me. Shoot, it's my kid's school. Hang on a second. Talk amongst yourselves. Okay. That would be great. Yeah, we have that. She has one. Yeah. All right. Thanks a lot. I appreciate it. All right. Bye-bye. All right. Well, that was interesting. They're actually calling because my kid doesn't have an updated physical and they have somebody there who can do one right now at school. And I told them, I said, yeah, that would be okay, except they better not ask her any weird questions. Like, I don't want them to ask her any sex stuff. I don't want them to ask her do your parents have guns in your house? Because that's nobody's business. And they said they wouldn't, but we will see. Sorry, guys, I muted it for a little bit because I didn't know what I was going to say. Yeah, I hung up. All right. And now Mr. Fox is texting me. Okay, I better get this started so I can deal with whatever the heck is going on. Hold on. I got to find day 12. Let's go to history because I was just watching it. So anyway, I agree with Rob that this witness, Dr. Kirkpatrick, he's the ketamine doctor. He is really hard to rein in, and it's a crack up to watch lawyers trying to keep him on task. He's like a super smart guy, and he has a lot of good things to say. I think he's a really good witness, but he is really gregarious and he wants to talk forever. And all right, here we go. Share screen. Let me get this started and then I can talk to Mr. Fox because he wants something.
Page 40, lines 19 through 20.
No, nothing was video recorded. I didn't hear that first word. What did you say?
You're required to do that by the Florida Board
Keep
of
medical
Medicine.
records, yes, correct.
As part of your medical records, you frequently videotape your encounters with patients in order to record their objective findings, correct?
Sometimes, yes.
Okay. You don't do that routinely?
No.
So when you saw the Kowalskis on September 23rd, 2015, that was your first visit, correct?
Correct.
And on that occasion, did you videotape your objective findings in your encounter with the Kowalskis?
No.
You didn't videotape any part of it?
Correct.
Not even the pain thresholds?
Correct. Oh, no, nothing was video recorded.
Okay. Do you remember when I took your deposition, or Mr. Hughes took your deposition on February 3rd, 2020?
I don't, well, I had two depositions. I don't know which one you're referring to by
The
date.
first one.
The first one?
Yes, sir.
I remember that, yes.
Okay. Do you remember the following questions and answers? Did you notice or chart any skin lesions? Yes. Your answer was yes. On the day in question, on September 23rd, 2015. Answer, I'm sorry, you said chart in my initial question, chart, comma, yes. Answer, no, I did not. But if you look at the video, there's some things you'll see in the video that weren't charted. But go ahead. One was a skin lesion on the right side, which you had most severe. And then I interrupted you apparently, or someone interrupted you. You didn't chart anything about skin lesions. No, I did not chart that. Now, why would you have said to look at the video for skin lesions if no video existed?
That was making reference to, which I do on all the patients that are about to undergo conscious sedation with ketamine. I video record their baseline function, pain threshold, so forth and so on. And on those occasions, not at the initial evaluation, but at the time just before the ketamine infusion, I do document those on a video recording. That is correct.
So in this particular case, when did you document on the Kowalskis?
In this particular case, the initial evaluation was on September 23rd. So approximately 2 weeks later, they came in for a pre-evaluation for the ketamine infusion. And on that occasion, a video recording was done documenting her function, pain thresholds, and so forth.
On October 6th, when you did the initial infusion?
I'd have to look at the date, but it's approximately 2 weeks after the initial evaluation.
You think it's too fast, Boosh? I'll slow it down.
Record from your office of any further evaluation before the initial infusion on October 6th?
Objection. Misstates facts.
Do you have your records with you, sir?
Not here, no.
Okay. Let's move on to the next issue.
Let's talk about the November 2nd video.
Objection.
No captions for whatever reason.
Objective predicate.
And the jury is not in the room yet. They're doing some kind of proffering,
Let's get into that.
I think.
Didn't you tell me in your deposition on March?
He's trying to figure out about the videos.
2022,
He thinks there are videos.
this patient was having suicidal ideation.
I don't recall that conversation. You're talking about during my deposition, I said such a thing. If you
Yes.
want me to look at the deposition and
I'll be happy
put
to
it
look at it
into
because
context, I'd be glad to do that.
my follow-up question about it is, you're saying your answer was, I'm trying to recall. That's, by the way, no, that I think at some point there we did document that on video recording the situation. That's your deposition. It's highlighted right there.
He's trying to
Right
prove
there
that there's a
where that
video
occurred in
that the
time.
doctor is withholding.
Let me think for a second here. I think where that was on a video recording was when she came back from Monterrey, Mexico, after being treated by Dr. Cantu, where there was a comment about she would rather. I think the comment. This is not a quote, but approximately what was said by the mother is that she'd rather go to Monterrey, Mexico, and get the ketamine infusion, and not wake up. Basically, that's not a quote, but I'm just saying basically, than to go on with life the way it was. That I don't think they used the word suicide in there,
Okay. Well,
or anybody did. I don't.
Let me try to orient you this way, Doctor. The records we have suggest that on November 2nd, 2015, after your series of infusions, but before the patient went to Mexico, you had a visit with these folks. And that's the subject of the question and answers that I just read to you and that you just read in your deposition. Does that refresh your recollection?
Well, you're trying to refresh my recollection about the dates. There was. I'm just trying to remember now. Let's see. There was a video before the ketamine infusion. There was during the ketamine infusion. There was one after the ketamine infusion. That would be number 4. No, number 3. And then after that, I think the next infusion, the next video that was done was when she came back from Monterrey, Mexico. I believe that's correct. I'm not absolutely certain, but I have records I could answer that in a flash, but I don't have that with me right now.
Where are they?
Well, I think most of the records are on my computer, which isn't here right now.
Let me ask you this, Doctor. Did you videotape any portion of the November 2nd, 2015 encounter with the Kowalski family?
I'm trying to figure out what November 2nd, what was happening on that date.
It was a follow-up visit following your.
Does someone have his records from November 2nd that we can put up on the screen to refresh his recollection?
Sure. If we could publish.
I've got it right here.
Okay.
Well, Mr. Reyes can put it up.
No, 1055 is the exhibit number. 1055-0032.
Yes, that one. Is that in evidence?
Yes.
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 Does this refresh your recollection, sir?
I'm reading it now. I believe, to the best of my recollection, that there was no video done on that day, Your Honor.
Thank you very much.
Can I have?
You can keep asking Mr. Hunter, but
Doctor, I'd like to show you a show you the text of an email exchange between yourself and certain members of the Anderson Gwynn firm. I'll direct your attention to your
Welcome,
email.
Habe.
It has the red arrow beside it with the C attached asterisk.
YouTube is ASO, American Dreamer. What can I tell you?
The date of the email is February 2nd, 2020. 12:36 a.m.
Yeah, I see the attached and I see the red arrow.
Okay. Did you look at the attachment?
Oh, it's in here? Okay.
You see the summary of follow-up evaluations of Maya Kowalski?
I see that listed, yes.
You see where you list in the initial evaluation of September 23rd, 2015, a pre-treatment video performed with pain thresholds recorded?
That's correct.
Did you in fact video a pre-treatment meeting with the family that day, September 23rd, 2015?
Not on that day.
With pain, well, why does it say that there?
Because it was pre-treatment. I was just before I was to do the ketamine infusion the next day.
Ketamine infusion, sir, was not done until October 6th or 7th.
Looking for the date.
Why would it say pre-treatment video performed with pain thresholds recorded if no such video was done?
I'm sorry, I can't
There
take the
was a
slow
video
speed.
done pre-treatment, and that was the day before the ketamine
This is not
infusion,
that
I believe.
important
That's-
anyway,
that's
because we're
correct,
not
yes.
in front of the jury. This is just,
So what date was that?
I almost
Well,
feel
the-
like
the day
skipping to
before
the
ketamine
jury.
Infusion, it looks like you have here recorded on here, or I have recorded on here. Let's see, pre-treat, post-treatment evaluation.
None of this
You agree
matters.
with me that paragraph reads, initial evaluation, 9/23/15, dictated initial evaluation, handwritten notes of the evaluation, period, new patient information form reviewed with the patient and mother, period, pre-treatment video performed with pain thresholds recorded, all of which appears under the date of September 23rd, 2015.
I
correct?
think I get your point, Counselor, but I think what I'm saying here
Really?
is that that date was not for pre-treatment. That was 2 weeks
Interesting.
later. So that video was done, that's referencing here, was done about 2 weeks later.
I hope they do.
No, it doesn't say that.
All right,
No,
I'm
you're
skipping
correct.
this because I'm bored as hell.
Dr. Kirkpatrick, apparently Beata Kowalski made
Oh, wait.
some recordings
Let's hear the judge.
of the appointments or a portion of the appointments on September 23rd, 2015 and November 2nd, 2015. Did you know you were being recorded by Beata Kowalski?
Your Honor, you mean on the 23rd, 2015?
September 23rd, 2015.
No, there was no video, so there was no, as far as I know, there was no recording.
No, what I'm saying is apparently Beata Kowalski did make recordings. Were you aware you were being recorded? Did you consent?
Sounds
to
like
be
he
recorded?
didn't know.
How about the same questions for November 2nd, 2015? Were you aware she was recording you and did you consent?
On that particular date, that was a date before the ketamine infusion.
No, it was 2 weeks afterwards.
Oh, 2 weeks after?
Excuse me, it was 20 days afterwards.
If there was no, the time I consent is when I do video recording. So they're usually, when I do a video recording, there's consent involved. But if there's no video recording, there's no consent. Is that helpful?
And you maintain that position today?
He didn't know he was being recorded, so they're not coming in.
What percentage of your video, of your encounters with your patients are recorded?
Well, the ones that are recorded usually are before the treatment, so I can establish a baseline in terms of function and, some of these objective measurements of pain thresholds and so
They're not coming in.
So-
The judge already said if there was no consent, they're not coming in.
Not always, no, because some might for educational purposes, but there's always consent. As for example, in the case of Maya Kowalski, she gave consent, the family gave consent for that to be posted.
But you wouldn't give consent that they're recording you.
In my office, I've got HIPAA material around. I'm supposed to protect my office. And if somebody's recording and I don't know about it, that's an uncomfortable position for me to be in.
Anything else, Mr. Hunter?
Yes, sir.
Okay.
I just have one question.
No, you don't. It's okay. The court's going to find, based on the totality of the evidence provided to me, that on September 23rd, 2015, and on November 2nd, 2015, that Dr. Kirkpatrick was unaware and did not consent to Beata Kowalski recording the audio portion of the discussion under Section 934.06 Florida statutes. Those may not come into evidence. So I'm going to need to know what numbers of those two, and then we're going to have to remove them from evidence because Florida law does not allow those unconsented recordings to come into
Right.
evidence.
If they're not a two-party, if they're a two-party state, they don't come in.
As Joint Exhibit 1076 and 1077.
Okay, what we're going to do is we're going to remove those from evidence. They will remain marked for identification purposes so that they will travel with the file, assuming that there's an appeal.
I knew that was going to
And
happen.
that no
All
one
right,
has
here we go.
approached you about this case. Is that
The
correct?
jury is back
And
now.
you've not seen any media accounts of this case. Is that correct? Okay, and our next witness, please, Mr. Anderson.
Dr. Kowalski.
All I know is that the
I'm sorry?
plaintiff did not, the plaintiff did not want it in, and it didn't come in. So I guess it's good for Maya.
Members of the jury, Dr. Kirkpatrick has already been sworn. So even though you have not seen him be sworn, I'm telling you he has been sworn. I appreciate that.
Please state your name for the record
Anthony Kirkpatrick.
and where do you live?
My home address is 849.
No, don't give your home address.
Okay, we're gonna-
Okay, sorry. Hillsborough County, Tampa, Florida.
All right. And you are an anesthesiologist and pain expert?
Yes.
All right, I'll be right back.
How long have you been in practice?
It's over 40 years. Plus, I just don't know exactly, but it's at least 40 years. I've been practicing anesthesia.
And you were the physician who first diagnosed CRPS in Maya Kowalski.
Correct.
I'd like to give you to give the jury a brief summary of your background, training, and experience towards what you'll testify to here today, beginning with your undergrad, if you could.
Okay, I'll try. So I got my bachelor's degree from the University of San Francisco. From there, I went on to get a master's degree from the School of Medicine in Portland, Oregon. And perhaps I should clarify or explain what pharmacology is. It's not pharmacy. It's where you go in and you learn how to develop drugs in clinical settings. You teach in medical schools, which I've done. So that's pharmacology. So from there, I decided to go on and get a PhD degree in pharmacology. And that was from the State University of New York. From there, I began teaching. I actually went to Stanford for a while to do some research. And then I ended up teaching at the University of Nebraska, teaching pharmacology as a PhD. And then I went back and had an opportunity with the courses I had to get advanced placement at Ross University, which is located in Dominica. And there I took some courses, but the main part of my training took place at the University of Miami in the School of Medicine as a medical student. And I got my MD degree. And then while I was there, I was invited to give lectures in pharmacology to the anesthesiology residents. And from there, the chief of the department suggested that I might want to do a residency in anesthesiology. I took him up on the offer. Now, we're going back over 40 years ago. And so at that time, the residency program was only 2 years. It was a very abbreviated type of residency compared to what it's now. While I was there, I began to develop an interest in the area of pain and how to control pain better as a resident in anesthesiology. From there, with my PhD degree and my MD degree, I accepted a position at the University of Illinois in Chicago. And in that capacity, I had an opportunity because of my PhD degree to do some clinical research, national multi-center studies all over the United States. I'm not going to go into details, but on a drug which is still used today. It's called esmolol. It's a drug. It's very rapidly acting. You can control the heart rate during surgery, that sort of thing. So I set up the studies for that nationwide, worked directly with the FDA and all that sort of thing. In the meantime, I accepted a position as an assistant professor of anesthesiology at the University of Illinois in Chicago. And I continued my interest in pain there and got involved in, I'm not going to go into details, but some research on local anesthetics and so forth. But also while I was there, I developed an interest in pediatrics in anesthesia.
All right, tell us about that.
Okay, so we had a hospital, one of the branch hospitals in Chicago focuses on ear, nose, and throat and eye surgeries. And they needed someone to kind of set that up so that one of the eye surgeons in particular wanted to be able to anesthetize, completely put to sleep under general anesthesia, children. And they didn't want them laying down like we normally lay kids down to do the general anesthesia. He wanted to be vertical because the instruments he had to look into the eye for diagnostic purposes were not suitable. So I tried to figure out what kind of drug to use in those circumstances. Because when you go vertical, the blood in your head goes down to your legs more or less. I needed a drug that would keep the pressure up. And of course, ketamine does that. It's the only general anesthetic we have which supports pressure. It's the only general anesthetic we have which supports breathing, so I wouldn't have to sit there and ventilate the patient.
Right, during the procedure.
During the procedure. So I put the patient in my lap and teach the residents how to give general anesthesia while you got a child sitting in your lap. And so that technique was developed. I spent a lot of time there teaching residents in anesthesiology about dealing with the pediatric population. From the unit.
How'd you get involved? Okay, so we're there. How did you get involved?
That's really important testimony, by the way. I hope you just heard that. Ketamine, and the people who work with ketamine know it's the only anesthetic they have that actually supports breathing. So when you hear the defense say that Maya was, in danger of her breathing stopping during the ketamine infusions, that's nonsense. The only thing that put her breathing into a question would be the general anesthesia that they put her under. That's why she had to be intubated. It's not the ketamine. It's the general anesthesia. So general anesthesia will do that to everybody. But ketamine actually supports lung function. So that's a really interesting and important testimony here, because the defense has been trying to say that the ketamine was putting her in this, massive danger, which is, from what we've heard, from what we've learned, that's not true. Otherwise, why would Dr. Chopra and his team of doctors in India have been given massive doses of ketamine to train crash survivors that they couldn't even reach? Like they couldn't, because they knew that it would support their breathing and not make it worse, right? So it's the only thing they can give for pain relief that keeps the lungs open. So yeah, that's important testimony.
Involved in the actual pain management part that led to RSE.
Right. The way that I got involved is that I was interested in a local anesthetic that would last a long, long time. There was a doctor there in the Department of Pharmacology who was dealing with these little teeny microscopic capsules of anesthetic because it was encapsulated, released the anesthetic very slowly. And so we went ahead and got a company started to develop that so that that could be used to give a longer acting local anesthetic. So that is where I got involved with the pain because that was the target. That was the clinical application we wanted to use. And so from the university, if I can move on.
Yes, I wanted to ask you
Sure.
a few questions in the interim. I forgot. You've received certain awards in your career, have you not, for your medical service?
Yes.
You've received the Governor's Award from then Governor Bob Martinez for contributions to science and technology.
Correct.
1989. The Abbott Laboratory Award for Excellence in Chronic Pain, involved the Department of Anesthesiology, University of South Florida in 1990. Is that right?
Correct.
The Governor's Award for Leadership.
Your Honor, please.
It's faster.
For this purpose, I'm going to allow it overruled.
Governor's Award for Leadership at the University of South Florida College of Medicine, presented by Governor Jeb Bush in 2002. Is that correct?
Correct.
And then a Dean's Award for Outstanding Service to the University of South Florida, presented by Dean Robert Doherty, MD, in 2002. Is that right?
Correct.
When you started out, was there board certification the way we know it now?
No, not at all.
So continue now. We want to get to the RSD Foundation and what you did starting with that.
Sure.
You can jump ahead to you and Dr. Schwartzman.
Oh yeah, right. So from Chicago, I went down to the University of South Florida School of Medicine. Took a position there in the Department of Anesthesiology. And it was during that time, I was really fascinated by this syndrome. We call it a syndrome, complex regional pain syndrome. I was fascinated by it. And back then, most of these patients were accused of being crazy, crazy, because there isn't any like a laboratory test you could do to make a targeted diagnosis like diabetes and so forth and so on.
What year are we talking about?
That goes back to 1988.
Please continue.
Yes. And so I was fascinated by that. And I became friends with a Dr. Robert Schwartzman. He came to the university to give a talk, and we made. He is a neurologist, and I'm an anesthesiologist. And he.
I've checked with bolstering into the hearsay and appeal to authority of this without foundation.
Why don't you ask more specific questions,
Yes.
Mr. Anderson?
Who is Dr. Schwartzman when it comes to the development of treatments for CRPS?
Judge, same objection. This is no problem.
Overruled on that one.
Yes, Dr. Schwartzman is probably considered the most highly published individual in the field of complex regional pain syndrome. Back then, by the way, it was called RSD, reflex sympathetic dystrophy.
Is that still used?
No. We finally got people to stop using that, but no, it's not used anymore.
Is there more than one kind of CRPS?
Yeah, we divide it down into basically type 1 and type 2 complex regional pain syndrome. Type 1 means there's no major nerve injury, at least evident.
Right.
And type 2 is where you got a major nerve injury. You knocked out your brachial plexus, your sciatic nerve, something like that would fall more into type 2.
What studies then did you and Dr. Schwartzman begin towards treatment of CRPS with ketamine? How did that work?
Well, it actually started with ketamine, and that goes way back, way before 9/11. And we were trying to see if we could, there was some reason to believe it has this target, the nerve pain. The pain is coming from within the nerves itself, as opposed to the type of pain you get when you injure yourself. Substances are released into your tissue, causing pain. When you get an ulcer that's inside your body, the same type of mechanism. It's not inside your nerves; it's substances released that trigger the nerve. And those are so the ketamine targets the nerve pain inside the nerve itself, whereas these other mechanisms we talked about, the injury type and the type that you get with an ulcer, those types of pain processes are not very responsive to ketamine. To do that, you almost have to. Well, you get pretty close to putting people under general anesthesia to really control the pain.
So tell us how the studies went. How did
Oh,
they
sure.
develop?
Excuse me, I have to be very quick.
let's move forward a little bit. Yeah, we can get up to Mike Kowalski now. These results of the various studies that you performed did indicate that ketamine was useful in the treatment of CRPS.
Yes, in the beginning, it was not doing what we call, the patients call ketamine coma, being put under general anesthesia provided. It was the low dose conscious sedation. The patient's awake, they can talk to you, but you're giving them ketamine. It's called conscious sedation.
So how did you discover this other procedure involving putting them under anesthesia?
One of the things we learned is that the benefits from the ketamine it's dose related. The higher you get the dose, the longer the response, the more vigorous the response. But there's a limit to how far you can go and still keep the patient conscious. There's going to come a point where you start to lose consciousness. And when that happens, the thing we concern ourselves with is protecting the airway, especially in children. Because children, when you give them ketamine, they tend to salivate a lot. So that saliva we all have is okay in your mouth, but it's got bacteria. It's not so okay if they get into your lungs. We call it aspiration into your lungs, and that can cause pneumonia. So remember, we're talking about conscious sedation. The patient can talk. They don't have a tube, an endotracheal tube, into the trachea to protect from the saliva going into their lungs, but they're awake. Your reflexes keep the saliva into your mouth. It's a protection we all have.
So how did the intubation, general anesthesia infusions work?
Sure. So to do a research study, you really need numbers. You really need numbers. Well, he had some patients there that were, now we're talking how we progressed. I'm sorry, is that what your question? How we?
No, I wanted to get across to the jury whether it was effective or not. The procedure, once perfected, whether it worked.
Yeah, it worked. It worked in the vast majority of patients. Conscious sedation with ketamine works. It gets them controls their complex regional pain center, the vast majority of them.
Now, in the studies that you did regarding the general anesthesia, were you under a review board at that time?
Yes, all studies that are clinical in nature, you have to get it done by an institutional review board. And at that time, we decided that it would be done by Drexel University, where he was professor and chairman of the Department of Neurology.
I'm trying. It's the same. So, doctor, now, did you ever have to turn into the institutional review board any bad results, for lack of a better term, out of the study using the anesthesia infusion?
Never had it.
Sustained. You need to move on.
Yes, sir. All right. So, doctor, did you begin private practice in Tampa, St. Pete area, and when?
Oh, well, no, I've been based in Tampa.
Okay.
And so, no, my practice has been primarily in Tampa.
Okay. And so when did you start treating patients in the Tampa Bay area?
That's when I arrived at the University of South Florida. That would put us at about 1988.
Right. And when did you stop actively treating patients as far as in anesthesia practice?
Well, I'm still practicing.
Okay. All right. So how did it come about that you met Maya Kowalski?
Okay. From what I understand, the mother, Beata, had heard about me through her contacts. Her mother is a infusionist nurse, and she'd heard from some of the other patients about me, and that at that point in time, there had not been a diagnosis, and the family really felt there was something desperately wrong with their child, and they needed another opinion, and they wanted to look at this possibility by consulting with me.
And was your first visit, I know you don't have your records in front of you, was your first visit on September 23rd, 2015 then?
Correct.
So tell the jury what you did on your first, the first visit.
Well, I have a policy, and that policy is that you always tell them how long the evaluation is going to take. Right. In a situation like this, it usually takes at least an hour to get through an evaluation. And I tell the patient the first thing I'm going to do is they fill out this we call the new patient information form. And I'm going to go, before I talk to them, I'm going to go over that material and see what I can get sort of a background, what I'm going to be confronted with.
Now, doctor, when your new patients come in, are you like just trying to confirm that it's CRPS, or are you looking for whatever the diagnosis is, CRPS, or it could be something else?
Well, you have to do the latter. You have to look for everything, because that's part of making the diagnosis. You have to rule out all the other possibilities based on the history, based on the symptoms, based on the signs that you witness. You have to be able to rule out these other potential diagnoses, or at least you can come up with a differential diagnosis may include more than one thing wrong with the patient.
Do you then try to avoid what is known as a confirmation bias? That is, everything that comes through the door is presumed to be CRPS until proven different.
well, confirmation bias. No, well, you have to fight that.
Right.
You have to fight it. You got to say, I'm here to help the patient. You can't help the patient if you're not can I use the phrase, an honest broker?
Got it.
Okay.
All right. So how did the examination of Maya go?
Well,
How did
she was in a lot of pain, and after a while working with children, you kind of learn of a way to communicate, to get them to relax and try to bring it down. At 10 years old, it's a challenge, but it can be done. You can try to get it down so they know that they're part of the discussion with the mother.
Right.
So we work hard to do that. And I also invite the child to be part of the discussion. So the first thing we do is most time when I look at the new patient information form, it's something like this, and it's incomplete.
Mhm.
So I'll go through it and I'll fill in the blanks with them as we go through it.
How did Maya appear to you in terms of maturity and intelligence for being 9 or 10?
Remarkable. It's not just intelligent. It's curious. She wanted to know. She's listening to what her mother says. I wish you got a child that's a little unique, different.
Right.
Not a little, a whole lot different.
Mhm.
So she's intellectually curious, very much engaged in the conversation.
So did she contribute then in going through and filling out the questionnaire?
Yeah, they both contributed to that process.
All right. So after that, what steps did you take to examine the child?
Well, I have a pretty much a head to toe type of examination, because remember what I said, you got to look for all the possibilities here, not just one thing
Sure.
that you've been doing research on. And so the first thing, like I say, I want to take a history. History is very, very important. I mean, the history is very important. So you're looking for, the whole history. Did it come from, how did this start? And then you go and work through all that process. And so you try to fit all that together and see if you can narrow it down a little bit, what's going on. And then, of course, there is the examination that takes place. And there I have a pretty standard thing from head to toe. It doesn't just look at just the one area. And then another thing I do, and this is something that I'm very compulsive about, is I want to set things up and do things that leave me convinced that I've done a very objective evaluation.
And what does that involve?
Well, that involves fighting the tendency to want to be biased. I mean, we always want our patients to do well, right? All right. So I try. One of the things I did since I started running the surgery center is I set up a new technology or a new methodology for measuring pain, not by numbers. You've heard this whole thing. Is it a 1? Is it a 2? Is it up to 10? 10 being the worst pain. That's for chronic pain. It's almost useless. For acute pain, it can be helpful. But for chronic pain, in terms of doing research, it's not very helpful. So I wanted to find a way so I could measure, without even talking to the patient, how much pain they're feeling between their earlobes.
And what did you use?
And what I used, I brought it today. I can show you if you want to see. It's a device called an algometer. And what it does, basically, first let me back up a little bit here. When you get CRPS and some other diseases, what happens as time progresses, maybe not initially, the body changes from being a local phenomenon, like you hurt your hand or whatever, sprained an ankle. It tends to progress into the central nervous system and into the whole body, the brain, everything gets involved. There's a word for it. I'm going to throw the word out and then forget it. Hyperesthesia. You'll find it in what they call the Budapest criteria. It's one of the things you're looking for when you do a diagnosis. Hyperesthesia.
All right.
And what that means is that all your senses, touch, sound, hearing, smell, they get accentuated so that you become very sensitive. So it was common for Maya to come in with dark glasses on because the bright lights were painful to her. But when she came in, the one thing that stood out more than anything else is her skin was exquisitely sensitive to light touch. Again, I don't want to use the big words for it, but I don't know what other people have said.
They've been well educated.
Have they? I don't know what other people have said so far, but it's called allodynia, okay? And it's like defined as any type of tactile stimulation, light touch, blowing on the skin is perceived as being painful. She had that. She had a bad case of it.
What other symptoms or signs did you know?
Well, she had the allodynia. But the point I want to make is you can touch them and forget. What this technique is called measuring pain thresholds allowed me to not only just detect it, but to quantitate the magnitude of it, of what she's feeling in her brain. And this device, by putting pressure on the skin, it gives you a number. It's called the pain threshold. So I tell the patient, look, I'm going to apply this device to your skin, and it'll feel like pressure. But I'm going to increase the pressure, and when the pressure turns to a pain signal, say stop. And we do it 3 times just for statistical reasons. 3 times we do that, and we get a number. And from that, and oh, by the way, one other thing that's very important: they're blinded. I mean, they don't see the numbers. They don't see nothing. So this is what I mean by being objective. So if a child comes in, let's say whatever, they want to stay out of school, so they're faking their pain, whatever. I can tell without even talking to the child if they are or not by doing this, the pain thresholds. It's a way to distinguish between what they're feeling in their brain in terms of pain signals as opposed to what's an emotional issue that might be evolving.
What, if any, other signs or symptoms were noteworthy during the initial evaluation?
The other thing that was noted, besides the generalized, the seeing problems and the touch, not just in her legs, but in her arms and so forth, measured with this device,
Right, but
was the dystonia.
Okay.
Dystonia is when the muscles contract due to the disease. Usually they're curling in. Sometimes they'll actually stretch out, but mostly there's flexion. And it can happen in the hands or in the legs. The interesting thing about it is when it comes comparing adults with children, we rarely see it in adults, but we see a lot of it in children. So if a child comes in with dystonia, you got to be thinking about CRPS.
Okay, I just want to point out what his testimony was just then was so important about how she was blindfolded while he was doing the pressure tests with the pain threshold machine. You can't fake it. And you can't, and I hope they hit on that more than just this, because they are going to, the defense is still going to say there was a psychological component. I know that we all believe there wasn't, but they're going to say that. I still have people in the chat who say she only got better because her mom is gone and her mother was wrapped up in this illness. It was her entire personality, blah, blah, blah. You can't fake this kind of reading on this kind of machine. So this is really important testimony, and I really hope the jury's listening.
Anything else in terms of signs or symptoms? First from the examination, and then I'll ask you about the history.
Yeah, well, I think in terms of examination, of course, we try to measure temperature of the skin, and we're always comparing the one side with the other. When the sympathetic, like I said, I have to go back a little basic. We knew from the very early, 30, 40 years ago, that this is a disease involving the sympathetic nervous system. And usually it's symmetrical on both sides. Your temperature is pretty much the same on both sides. But when you get the CRPS, things get disconnected so that one side may be cold, the other side may be hot. So I took out a device, which I brought today, if anybody wants to see it. It's called infrared scanner. And I want objective information. So it measures down to 1/10 of a degree. So I measure for differences in temperature. Now, on this particular occasion, there was some difference, but it didn't reach my satisfaction for a significant difference from a medical standpoint. So I didn't record that there was a difference in temperature.
Okay.
Keep in mind that this is a disease that's labile. You come in one day and there's a difference. One side's warmer, one side's colder. If you think about it, there's going to come a point where they're kind of they're the same when they're fluctuating like that.
Any other signs or symptoms from the physical examination?
That
you can think of?
From the physical, let's see. Yeah, there were, yes, on the right side. Now, with this device, I'm able to tell you which side is worse, the algometer. I'm able to tell you which, her right side was worse with the CRPS, the sensitivity, and she had lesions on that side. And they typically are like, they look like little dots almost sometimes, but they sometimes will break up and then they actually become an ulcer where they break through the skin.
Okay. And then very, very briefly, the history given, what was significant to you now that you had these physical signs?
Well, for me, there's some things that just glare at you. Hey, this is CRPS, complex regional pain syndrome. Right. The main thing is allodynia. There is nothing we know in medicine that causes this exquisite sensitivity to light touch than CRPS. There doesn't exist. Okay, doesn't exist. And so that just right away, that became a very big deal. And of course, like I said, in children, the dystonia when they get CRPS is so common that there. So putting it all together, the dystonia, which is a sign, and the which means she couldn't walk. Right. She couldn't bear weight.
She was in a wheelchair?
And she was in a wheelchair. And she had the real sensitive skin, which you couldn't touch in certain areas, especially in her lower extremity, especially on the right side.
Let's jump ahead. So you made the diagnosis of CRPS.
Yes.
And you confirmed it with your testing?
Yes.
And so how did Beata present to you through this initial evaluation, the mom?
Well, it's kind of funny because I was talking about Maya being so intelligent and so inquisitive, and that's her mom. They have the same DNA. Yep. You know, she's the same way. She wants to know details. She's very medically oriented, and I like that. And to me, it's refreshing to have a patient that gives you a little bit of a challenge. I enjoy that.
Did you find her determined or any other characteristics?
Well, she
sign of a good doctor.
I mean, she loved her child. And you know what? The child loved her mother.
That's a really good thing.
Yeah.
All right. So now you've made the diagnosis. What did you prescribe as the initial strike that? Did you check to see what different therapies Maya had already been through?
I did. And I looked at particularly those places where she had the usual customary treatments for CRPS. Physical therapy, maybe occupational therapy, and cognitive behavioral therapy. Those are the big things that you think about in the beginning. And I did think about those, and I did explain to them during the evaluation. Our job is to get the legs moving. If we don't get those legs moving, especially what we're looking at right now, it could, well, she asked me what could it be, and I told her the truth. She could form blood clots in her legs, and they can break off, go to her lungs, and it could be fatal. And the problem with that in children, especially in children, it's a silence. It's silent. It's hard to diagnose because in adults, when we get a pulmonary embolism in our lungs, you get chest pain, you get a feeling of apprehension, something ain't right. Kids, they just don't wake up in the morning. So that's one problem. The second problem is if they do get it, it's hard to treat. Why? Because remember what I said, they have the allodynia in their legs. Normally what we'll do is put them in pressure socks. Their skin is exclusively sensitive to light touch. So that limits your treatment options in that situation.
So what type of therapy did you suggest or prescribe to start with?
I told her that if she can possibly get into some heated pull exercises, that would be recommended.
And did the Kowalskis follow your prescription, if you will, and find ways to heat up their pool?
Yeah, I understand they set up some kind of a solar system, yeah.
So how long did the warm water therapy last, the best of your knowledge, before they were asking you if there's anything else could be done?
Well, I think they came back and because I don't have the evaluation here in front of me, but they came back.
Duncan, Idaho, thanks for the super chat, says, how the F can you watch this trial up to now and conclude anything other than criminal abuse and massive overreach on the part of the hospital and state? How could you still believe the Munchausen BS? I don't know, but there are people who still do. They still do. And if you're one of those and you want to talk about why you still believe that in the chat, you're welcome to do that. Just don't get upset if I push back. I've seen too many women accused of this disorder, this very, very rare disorder that I'm not even sure is a disorder, and I think is more of a misogynistic weapon that doctors use against mothers who disagree with them, mothers who are too interested in their kids' medical situation. I liked what this doctor said, what Dr. Kirkpatrick said about Beata, that he welcomed her medical knowledge. You know, she was a nurse. And he said it was unusual, and it is unusual. Parents don't often push back. They don't often ask, challenging questions to doctors, and only the good doctors like that. And you could see he loved it. He was like, yeah, it's a challenge to have a parent that's that involved. He loved it, but not very many doctors do because they take it as a personal insult if you question them. A good doctor won't. A good doctor will just get down into the weeds with you and will explain and argue their point. A good doctor will not treat you like you're a nobody nothing whose opinion should be discounted and thrown away. And that's the way they treated Beata at Johns Hopkins.
And she had a kind of an exacerbation of her symptoms. And then taking, and this is important, taking in consideration she's exhausted in moving forward with her symptoms and problems medically with the usual customary treatment, the physical therapy, the PT. And by the way, if they don't know what they're doing, PT can actually make you worse.
Right.
So they tried all those things. In fact, she spent a month, I think it's about a month, at Tampa General Hospital. Right. I know their program because I was there for over 20 years. I think it's 20 years. I was there for over 20 years on the attending staff there. Yeah. And I know the program, and that's what it is. And so they've been through all that, the psychotherapy, all that, and she was just getting worse.
So what was the next step for a reasonably prudent physician, pain physician at this point? Right.
Having had the experience of doing those, over that 2-decade period, we've done a total of probably, we've probably done, be exact, 43 patients with ketamine coma. I didn't think of that right away. That was not what I thought about. What I thought about was, let's try a low dose conscious sedation where she's awake. Now, mind you, and this is I explained this to them because her mother asked me, you said, Dr. Kirkpatrick, that she will lose her memory temporarily, short-term memory. How long does it last? That's what I mean. That's the kind of mother she is. Okay. Right. She's asking questions all the time, and it's temporary, but it's important that we give enough ketamine, because remember what I said, it's dose dependent. You have to get the dose up. So we want we want that temporary loss of memory.
Is that
But-
the resetting process?
Right, exactly. And so,
Oh,
we
that's
don't
so
want to
interesting.
get the dose so high for safety reasons that the secretions could end up down in the lung.
That is so interesting, you guys. Look at what they've discovered. And I'm learning so much in this trial. It's so interesting about this particular syndrome and how to stop it. So basically, what he's saying is you've got to have the dose high enough to interrupt the signals from the brain. And being able to do that will result in a temporary loss of some memory. But that's what stops the pain signals. Isn't that interesting? Gosh, this is so, you got to be grateful for doctors like this who do the research and are tireless about finding out how to stop people's pain. Because I swear to God, when you go to the doctor and you're in pain for something, they barely want to give you anything. They treat you like a drug addict. I've never had a doctor like this who would just go, with you all the way through to find a way to stop it, no matter what they do. I mean, no matter what's going on. I mean, it's just amazing. He seems like a good doctor to me. I would like to have a doctor like this.
And down in the lung. So the way we prevent that is they're always conscious. So they do not lose their long-term memory. Who's that over there? Well, what's her name? That's my mother. Or the mother is actually there in the room with the child. That's another thing we found very important. Children, it's really important kids to have the significant other there. If it's a mother or father, there in the room, because what happens sometimes they start feeling the room's getting bigger, getting smaller, they get a little frightened. There's the mother over there. Dr. Kirkpatrick isn't trying to poison me. I know who that is. That's my mom. She's here to protect me, because you do lose your sense of it. But kids, we knew this for decades. Kids don't really hallucinate the way adults do. Adults can get really bad hallucination. We rarely see it in kids, rarely. But nonetheless, the point is mother's there, and we constantly ask them, what state do you live in? What country do you live in? So we always are communicating back and forth to make sure we don't overshoot.
I'm trying to move along. Yes, Doctor, we'll try to confine the answers a little more to the questions. I know you have a lot to say on this.
Anderson is starting to freak out because this guy, he's so interesting though. Look at how I'm interested, you're interested. I'm sure the jury is on the edge of their seats, but Anderson's running out of time. And so he has to direct his witness to stop talking as much as he is. But that's unfortunate because everything he has to say is so interesting and helpful, I think. But he's running out of time. And I think that's why he's responding like this. And it's hard to rein in a guy like this who's clearly just really, really knowledgeable and excited about what he does. And so he's so engaging. Colin wants to know, can I be your mom on the internet? Yes, I'm everybody's internet mom. So if you need some mom advice, let me know. I'm happy to dole it out. If you need some mom shaming, I'm also here for that. But super chats would be appreciated.
Sessions, if you recall, did Maya go through the outpatient type, if you will?
Yeah, there were 4, and they were 4 hours each.
And the dosing, do you remember what it titrated up to?
Yeah, I just happen to remember. It was about 135 milligrams per hour. Yeah, about that.
And what were the results?
The results, there was some evidence of improvement, but in the legs, which concerned me the most because of the possibility of pulmonary embolism, there was hardly any movement at all. That was my biggest concern. And I think the time is ticking, because a pulmonary embolism is something you can say, well, it's going to happen 3 days. It can happen at any moment. And you got a crisis on your hands. So that made some sense of urgency to the situation.
So how did you then respond if your outpatient infusions are not working? What was your suggestion?
My suggestion was that based on my experience of having done other kids with the high dose, the anesthetic dose of ketamine for 5 days, that would be something for them to consider carefully. And the way I wanted to make that happen is I put them in touch with some other children that we've done in Tampa. I mean, from our surgery center, and they've given permission to disclose their name. In fact, they posted their stuff up. But the point is, we had 2 kids that had gone down to Monterrey, Mexico, that had that done, and so I put them in contact. I said, don't make a decision, talk it over. I put you in contact with Dr. Cantu down there. Here's his phone number. I will send him all your records if this is something you want to do. And we do go through. This is not a research now. Keep that in mind. This is about treating Maya out because she needed some urgent care to protect her.
Let me ask you about your relationship with Dr. Cantu and his clinic there. Do you get referral fees or anything out of this?
No.
And do you do a pre I guess before they fly down there, do you do an examination to see if they're physically ready?
Yes.
And you get paid for that?
Yes.
So then they decided to do that, to go to Mexico?
Yeah, well,
where else is it offered, by the way, besides Mexico? Is there any place else?
No, to my knowledge, at that time.
Had it been offered in Germany before?
Well, Germany, as far as I know, it's so far away, and so Dr. Schwartzman and I decided to move in another direction. And the other thing about it is Dr. Cantu, again, I don't want to spend a lot of time on this, but he had a patient he wanted me to help with. I flew down there to help him with the patient, put that patient under general anesthesia with ketamine for a week, and she did fantastic. And so with that, we decided to try to get institutional review board approval to do patients in a study.
Dr. Kirkpatrick, I really need you to answer the question that's asked. And I know there's a lot of other information, but it's important that you only answer the question that's asked.
It's like herding cats.
I understand.
I appreciate it.
We're on limited time here. Okay, so did you speak with the Kowalskis or otherwise find out how the ketamine infusion down in Mexico went after they returned?
Yes.
And how was it?
It's great. She started moving her arms, and she had full function of her arms. She could take care of herself. She could comb her hair, brush her teeth, eat with her hands, and so forth.
All right. Now, was it necessary at this time do you terminate the ketamine infusions, the outpatient, or do you try to keep up with these? And if so, why?
Well, we have found over the years that sometimes these patients, after they have, not all of them, but some of them, after we do them, they have to have what they call it a booster. Okay. They come back. Remember what I said, it's the conscious sedation. They are awake when you do it.
Got it. So they need a booster.
A booster, yeah.
Right. What about after the booster and they come back to the United States? In Maya's case, did she continue with ketamine infusions as necessary?
Yes, she did.
And who did you refer them to?
Dr. Hannah.
And why Dr. Hannah?
Well, we're a research center. Again, trying to keep this succinct as I can.
Okay.
We're a research center. So most of my patients are coming in and they're paying out-of-pocket cash. Okay. And the reason for that is we can't do research unless we have money. And that money comes from...
Hang on. Let's
okay, sure.
Just stick with that. And so then why Dr. Hannah? Because you're a research center and you're not set up for
insurance.
Yeah, and for long-term infusion. I mean, to keep going steadily as necessary.
Right. And the other reason, I knew him well. He's my next door neighbor across the bridge.
Okay.
I knew him. I've been to his facility. I know what he does. He's one of the most caring doctors I've ever met when it comes to patient care.
And so then, were you aware at this time that Maya had eventually had a port put in to facilitate the infusion?
Yes.
And do you know what hospital that was done at?
Johns Hopkins.
If I could show, publish in evidence 2041-036. I believe this is from Dr. Elliott, I think.
And those of you asking about the time limits, yes, both sides have the same amount of time. I think Anderson's case is down to about 4 hours or less at this point, so he really needs to hurry it along. I don't know how many more witnesses he has, but that's why. Both sides have the same amount of time, and you can hear at the end of every day of trial, the judge gives an update as to what time they're at.
Johns Hopkins actually put the port in.
Correct.
And through the course of 2016, did you ever receive a call back, leaving out eventually the October events, but did you ever get a call back from anybody at Johns Hopkins that was questioning or concerned about Maya having received the ketamine treatment?
No.
In Mexico or with Dr. Hannah?
No.
And to the best of your knowledge, how was Maya doing over the course of the spring and summer?
When she came back from Monterey?
Mm-hmm, yes.
Yeah. She was, well, I did evaluate her when she came back.
Okay.
And she had full function of her upper extremities. I don't recall there being any.
Excuse me, Counsel. I'm sorry. Can we get a date on this?
When
he's talking about evaluation he did, I'd like to know what date.
Oh, sure. Doctor, did you do an evaluation in 2016 or was this from accounts reported to you?
I did do evaluation. It was about 2 weeks after they came back, roughly.
Okay. All right. Okay. So through the course of this time then, nothing from Johns Hopkins. And then did you learn that Maya had a relapse in the late, well, I guess it would be early fall, very late summer?
I think I did, and I don't know how I got it, the information, but it had.
You don't have the source of information. This appears to be hearsay. He's testifying third-hand information.
Madam Court, can I have a question back, please?
Question. Okay. All right. Okay. So through the course of this time then, nothing from Johns Hopkins. And then did you learn that Maya had had a relapse in the late to
late, well, I guess it would be early fall, very late summer.
I
Overrule the objection. You can answer.
I can't recall that specific. The one thing, well, anyway, I don't recall something that of that nature. I think there was, but I'm not absolutely sure about it.
Did it come to your attention that Maya was checked into Johns Hopkins All Children's Hospital in the fall of 2016?
Yeah, yes, I'm aware of that.
All right. And did there come a time that you had a conversation with one of the doctors there? Did you ever have a conversation with Dr. Smith?
Yes.
And tell the jury a little bit about how that came about.
Quick. The way it came about was that I had received a notice, and the notice was that they wanted medical records, and so I was wondering what that was all about.
Okay.
So I called. I found out it was Dr. Smith there at the hospital that was doing the investigation.
Okay.
So I called, and she wasn't immediately available. She called me back.
You have a conversation with her then?
Conversation, right? And I thought this is going to be easy for me because on my committee I have a scientific advisory committee I'm the chairman of, and she's on my committee, Dr.
Objection, Your Honor. This is not responsive to the question.
Let's get the next question.
Right. Let's pull up then 2118-036. I believe it's partially redacted. It's a note from October 11th, 2016.
I don't believe 2118-036 is in.
This is not it. That's not it.
It's not.
It's within this one.
I thought it was 36, 37.
Yeah, this is 36.
I thought you said 26. I'm sorry.
2118-36.
Okay, my apologies.
Oh, for fuck's sake. Make sure you hit the like and subscribe button. On Rumble as well. How are you, Rumble peeps? Don't forget, you can send Rumble rants and now super chats on YouTube because I am not demonetized anymore. Don't forget to hit that like button.
Who called who, by the way?
I called her.
And through the course of this, then you had, I gather, a conversation about the Kowalskis.
Yes.
And what was your concern here, having received the request for medical records and knowing that Maya was over now at Johns Hopkins All Children's Hospital? What's your general concerns about this?
Well, the day before, I had sent a message to my to Beata, the mother, and I hadn't heard a while from them, so I was curious what was going on. Then I get this note for records, and I'm going because I want her to come to see me to reevaluate Maya, and now they're asking me for records, and I don't know what was going on. So I called and talked to Dr. Sally Smith, and she represented herself as being a part of the medical staff there at All Children's.
Excuse me. Objection. Hearsay is called the witnesses editorializing about who she's associated with.
Why do you think?
Well, I'm going to overrule that objection.
Let's look at, and what I'll represent to you is a personal note from Dr. Smith of October 11th, 2016.
Welcome to the Fox Den Examoon, new member on YouTube.
As to the different topics that at least Dr. Smith took down here, if I recall. So what did you discuss?
Excuse me. Objection, Your Honor. The witness said he didn't have a recollection of this. He's being shown somebody else's record to comment on it.
Speaking of objection.
Let's go to only legal bases. Do you recall the conversation?
Yeah.
So you don't need the notes to refresh your recollection?
I did it right after the conversation. I documented a memorandum.
That's not in evidence. We can't talk about this.
Okay,
It'll just
all
be
right.
this.
Well, I can remember what's on the memorandum if that's helpful.
Okay. Then
why don't we take this down and then
I'll
you just
just
answer Mr. Anderson's specific question and only the specific question.
Yes. Tell the jury what you told Dr. Smith. I'm sorry. Did she ask you any questions before you told her things?
No, she didn't ask me anything.
What did you tell her?
I said,
You can answer.
yeah, I wondered what's going on. I understand you're with, Johns Hopkins, and tell me what's going on with the child and why I'm getting asked for records.
Did she give you a response?
Yes, and I can't remember the exact, words, but basically she was saying that there was a doctor over the weekend that saw the child and was concerned because when they lightly touched the skin of the child would jump, and that didn't make any sense to them. And they mentioned something about, that didn't make any sense. And it was not just in one area. It was pretty much both upper and lower extremities. And that didn't make any sense. And they were concerned that they by the history that had been taken, that this might be some kind of a child abuse situation, and that really got me very concerned about the situation.
Before you tell us what you told her, in your experience, is it common or uncommon for doctors not familiar with
Ooh, the
CRPS
defense is going nuts.
to jump
What's
to a
going on over
psychological
there?
conclusion before finishing their differential diagnosis?
Correct.
Legal basis.
Irrelevant, overbroad, vague, has nothing to do with the situation that we're addressing.
It has everything to do with it.
Yes, it is, because this is a neurological disorder, and it has some signs and symptoms, and it carries with it a history. And if you don't know about that, it may seem a little bizarre. How is it that this child can have this sensitive skin all over?
So you'd seen this happen before, where?
Oh yeah.
And so to, I guess, to protect your patient, what did you tell Dr. Smith?
Well, when she suggested the Munchausen by proxy, and she did mention that, I said, well, with due respect, she has
You're a
multiple
moron.
objective findings that far exceed the criteria that we accept as a standard of care right now. The Budapest criteria far exceeds those requirements.
So you told her about.
It's absolutely clear. There's nothing. This is it. This is what you got. And I said,
So hang on. So you told her about the Budapest criteria, that was the standard.
right. That was the standard of care.
Okay, and then
Leading, argumentative, and need to have questions being responsibly answered.
I'm going to overrule the leading, and let's just make sure you answer only the question that's asked.
Yeah, I'll give you cues there. All right. So now I forgot where I was.
Oh, great.
I was asking, did you provide Dr. Smith with the criteria to use in evaluating CRPS?
I did. I pointed out my findings. Yes.
Did you tell her how your findings met up with the Budapest criteria?
I did.
Did she say anything?
No.
What else did you tell her?
Well, I emphasized that the findings were objective, could be easily verified, assuming, stating that this is not something that's my opinion. It's really something that's documented, not just by me, but in the scientific literature. And
do you know what overall? Do you know what Dr. Smith's specialty was? What kind of doctor she was?
Pediatrician.
And so, was that a concern to you that whether she had the training or ability to recognize this?
It should be.
Should she have been able to recognize it as a pediatrician?
If we're talking recognize the CRPS.
Yes.
I don't think the average pediatrician would. Well, I wouldn't say that. It's just that. I got the impression she just didn't really know hardly anything about what we were talking about.
She was a moron, in other words.
Because this is the most painful disorder you find in kids, that they would know about it. And especially since the kids come in, as I said earlier, with a very unique picture in front of your face, the dystonia.
Your Honor, excuse me.
So forth.
We're editorializing beyond the scope of the question.
I thought that one was
Getting
Defense
fairly
hates
close to
this.
Opinions that this witness does not have statutory competence to make.
Yeah, overrule that objection, but sir, I really need you to only answer Mr. Anderson's questions without adding on anything.
Okay.
It's really
I'll work on it.
Well, I need you to do more. I need you to do that because it's
Okay.
really important that you do that.
Sure.
Did you warn off Sally Smith from accusing this family of Munchausen by proxy?
Yes.
And did she respond to you with any particular questions about what these symptoms were or why you were warning her off?
No.
Did you tell her about the allodynia?
Yes.
Did you tell her about the dystonia?
Yes.
Did you tell her about temperature changes?
Yes.
Did you tell her about the, and I'm not sure you documented this, sweating or any other?
So this is interesting. This is the first time we've heard that Johns Hopkins did reach out. And so they were told that she did not have what they thought she had, that her mother was not Munchausen. Isn't that interesting? Flux, thank you so much. I got your Cash App. Flux sent $5. It says for Fox mom is best mom. Thank you so much, Flux. I love you. How's the neck doing? I hope the Epsom salts are working. So this is new information, right? Because we were under the impression that Johns Hopkins never reached out. So it appears that they did, and then proceeded to ignore her treating physician. Wow.
Symptoms and signs that you had noted.
I don't remember those in particular, but the ones that I had documented, I did reference those to her.
All right. And so how long was this conversation?
I would estimate maybe 30 minutes, something like that, approximately.
And did you explain to her about generalized neural sensitivity?
Yes. Oh, yes.
And so after all of this, again, any response from Dr. Smith of an inquisitive nature about what the distinction was between Munchausen by proxy and CRPS?
No.
Now, in follow-up to this, did you have any more communication with either Dr. Smith or the hospital about this situation? The situation being Maya Kowalski in the hospital and a diagnosis of Munchausen by proxy as to the mother?
No.
Mm-hmm. Mm-hmm. All right. I guess that they're
The
are they
embolism
doing a
we spoke
sidebar?
about before.
Nope. I
Did
guess not.
Beata Kowalski question you about this, I don't want to call it phenomenon, but this circumstance that this embolism was a danger potentially to Maya?
Yeah, she did query me on that.
And did she continue to follow up about this?
Yes.
What did you tell her? Strike it. What did she tell you about her concerns over improper care of her daughter?
I think her concern was
Hearsay and standard care.
Overruling the standard of care, I think I'm going to sustain the hearsay nature of that question, though.
3 or 4, 803, 3 or 4. What's the?
I don't think you've got a foundation for that question for that exception.
Did you still consider Maya Kowalski under your care?
Yes.
And were you attempting throughout this period to keep yourself apprised of Maya's medical condition?
Yes.
Did
Objective foundation, Your Honor. The record will reflect this witness had last seen the patient 10 months ago.
Let's, again, no speaking objections, so let's not do that.
I'll be happy to approve.
I don't need an approach on this one. I'm overruling it. You can continue.
And from time to time, did Beata Kowalski provide you
Overruled.
with updates on how Maya was doing over the course of the spring and summer of 2016?
Yes, sir.
Did she continue to use you as a source of information about Maya's progress and symptoms and treatments?
Yes.
So at this point, when Beata called you in the fall of 2016, was it for the purposes of updating you about Maya's care and her concerns?
Objection, Your Honor. He's asking for the state of mind of another.
Sustain that question.
What, if anything, was the purpose for that last call in the fall of 2016 between you and Beata Kowalski?
Same objection.
Overrule that one.
I'm not sure what date you're talking about here.
Did you have, during the fall of 2016, did you have any conversations with Beata Kowalski where the topic of
How about
embolism?
when was the last time you talked to her? And what'd you talk
that
about?
Conversations was before then, but yeah, she brought it up. She mentioned that her legs aren't moving. What is she going to get clots down there?
And to the best of your knowledge, did she participate in various, with this disease, were there chat rooms and websites where CRPS patients and their child?
Greg, strike that Anderson.
Information about the disease?
Yes.
That's his
And
new
to the best of
name.
Your knowledge, based on what she told you and your own knowledge, did Beata Kowalski participate in those from time to time to learn about CRPS?
Yes.
Objection, hearsay foundation. Overrule.
So in this conversation then, did Beata ask you any questions about what would happen to your daughter if she continued to have care that was inappropriate?
God, why can't he ask a question properly?
Yes.
So now he can't even get the question out. The judge ruled in his favor. He overruled the objection, but Anderson can't get the question out in a way that the witness can understand it before he gets another objection. It is so frustrating. Where is his junior partner? Where is the other guy? The guy who asked direct questions? And why the hell isn't he doing some of this questioning? Crazy Warlock on Rumble says, but Anderson is kind of a bumbling moron. Yes, that is the way it appears. And I don't know why he continues to be given the long leash here. I just, good God. I don't understand why we're not using the other attorney on the team who asks very good, succinct questions. We are having a time crunch right now. We don't have time for this, Anderson. We don't have time for your multiple strike that questions. We don't have time for you to start a question 3 times and strike it every time before you get to the right one. I've forgotten already what the freaking question was. Does anybody know? What is he trying to get out there? What is he trying to say? Because I still don't know. I have no clue. All right, it looks like they are, let's speed it up.
Goes to the lungs. It could be fatal.
Wait.
Any other questions, Mr. Anderson?
Oh.
What was Biana Kowalski's concern expressed to you in this conversation?
About blood clots forming in her feet, in her legs.
What happens if those go untreated?
I think I mentioned that it's a silent pulmonary embolism. Goes to the lungs. It could be fatal.
Did you tell Biana Kowalski this in that conversation?
Numerous times when she asked. And the other part of it, counsel, is that I emphasized that if she doesn't get the ketamine, it's gonna be a slow, painful death.
No further questions.
Members of the jury,
Finally.
going to take a hopefully
All
no
right,
more
we're
than
going to go to a break, and then when they come back, they'll do cross, and then they'll do jury questions. So let's get to the cross. Is anybody else getting really sick of Anderson only being able to speak a few words at a time so we can't understand the meaning? I mean, my God, man. My God. Perhaps the legal profession was not your thing. Perhaps you're better at research and writing reports and stuff. I don't know. Like maybe you're a legal scholar. Maybe you're a legal genius.
receive the information or anyone approaching.
When it comes to writing motions and stuff. But if you can't get a sentence out, if you can't spit it out, if your brain doesn't work fast enough to put one word in front of the other in a full sentence with your accents where they need to go and all your syllables in the right place, then for fuck's sake, let somebody else do it. Let somebody else do it. This is why I believe that lawyers should be able to hire people like me to ask questions. Like, just give me a list of stuff you want asked. I'll get it out there for you. Okay? This is frustrating as hell.
Is that correct? Correct. And did not see any media snippets or anything like that. Okay. Mr. Hunter.
Good afternoon, sir.
Good afternoon.
Let's see, you described to the jury earlier.
Today, Junior.
Background and training. Not board certified?
No.
Not board certified in
Oh, here we go.
anesthesiology or pediatrics?
Correct.
You've never been board certified in anything?
Correct.
Isn't it true that you are not board certified in anything? As if board certification means anything. I mean, I'm not really sure, but I don't really care. Based on what I've heard from this guy, he doesn't need board certification because he has a lifetime of experience.
You weren't telling the jury that there wasn't a board certification when you went through residency, were you?
No, I didn't say that.
Okay, there was.
There was.
But you're not board certified, never have been.
Correct.
Okay. You don't have any hospital privileges at this time?
Correct.
Haven't had any in a number of years, correct?
Correct.
And your clinic, institution is on East Bush Boulevard in Tampa?
Correct.
It's out near Busch Gardens?
Yeah.
Oh, for the love of God, Hunter. This attorney has now just did you hear that? It's by your office is by Busch Gardens. You know what he's trying to say to the jury. I would object to this. This should be objected to. He's trying to say to the jury, I mean, what's the relevance? Objection relevance. Where if his office is close to an amusement park. What you are trying to tell the jury, what you're insinuating to the jury is that he's a circus performer, aren't you? That's what you're doing. You're saying your office is next to a bunch of amusement parks. You're a carnival barking snake oil salesman, aren't you, sir? That's what he might as well have said by saying, yeah, your office is, it's near Busch Gardens, isn't it? What the actual hell? Why would the judge allow that? Why would he allow that? Yes, Elsie Merritt. Do you live in a van down by the river? That's absolutely it. That's exactly it. Let's see if Anderson objects. Any bets on if he will? No objection.
You have not done any specific research with.
No objection to that. No objection to your office is next to Bush. Your office is next to the Magic Kingdom, isn't it? Isn't it? Tell me, sir. How long have you been a neighbor of Mickey Mouse? Tell me. Tell me, sir. How many times have you gone to Busch Gardens to get your face painted like a clown? Why did Anderson not object to this?
With respect to the pediatric population, have you?
Specific, just only pediatrics? That's your question?
Yes,
no,
sir.
I have not.
And you're aware that ketamine is not known to be safe or effective in pediatric patients below the age of 16.
I don't think that's correct.
Doesn't the manufacturer admonish you that the safety and effectiveness in pediatric patients below the age of 16 has not been established?
Oh, sir, if you ask the question that way, yes, I agree. I agree with you.
Let's talk about the first time that you saw the Kowalskis. By the way, where are your medical records?
Elsie Baird, your office is between the Pizza Hut and a Kinko's, isn't it, doctor? You practice law, you practice medicine out of a strip mall, don't you, doctor? Now tell me, doctor, are you a strip mall doctor? This is so ridiculous. But this is exactly like what he is asking. Yeah, this would have been great will call if the doctor had said it's down the road from the university in response to, is it near Busch Gardens? He could have said it's down the road from the university. That would have been better. But I mean, who cares if it's near Busch Gardens? A lot of things are near Busch Gardens. Yeah, thank you for pointing this out, Kimmy. Tylenol says it shouldn't be administered under a certain age either, but people still give it to their babies, which they shouldn't because now it's been implicated in autism. But yeah, I mean, there's a lot of things that the FDA doesn't approve that are used off-label because doctors like Dr. Kirkpatrick have done all kinds of research on and testing on it. And there's a right to try law. So there's a right to try law that says if you are a patient I'm not sure exactly what the law says, but I know that there are laws about having the right to try medications off-label for your particular problem. If there's nothing else available. I am the princess says, oh, is that anything like a strip mall lawyer? Yeah, that's where I was going with that. Are you a strip mall doctor? Safe and effective. One of the most useless turns of phrase ever. Yep. Nothing is safe or effective. Some things are effective, but they're not safe. Some things are safe, but they're not effective. Safe and effective, you don't get that very often. God, I can't believe Anderson let that go.
I think they're on my computer.
Oh, and where are your files? Did you bring your entire... Tell me, Dr. Kirkpatrick, where are your files? Why haven't you rolled them in here? Where are your files, Dr. Kirkpatrick?
They are on my computer.
Where would that be?
On my laptop. It's right now. It's back at the hotel.
So you can't.
Wait. This is what Hunter's going to say next. You are testifying in this trial about the medical situation with your patient, and you didn't bring any of your medical records with you? Let's see.
Came here today to testify about this case before this jury without your medical records?
I was told that they had that what's in evidence is my records.
Yeah, it's all in evidence already, asshole. Everyone has the records.
My medical records.
Notice Hunter has nothing to say to that. He just goes, okay.
Okay, so we'll work off that. The records we have suggest the first time you saw these people.
Oh, so you have the records. The records we have show. So what was all that about? Where are your records? You are literally sitting on his records. You have his records. This is so frustrating.
It was September 23rd, 2015. Is that right?
Yes,
And before that date, you'd had no communication with them, right?
correct.
And you knew that they had seen a number of other physicians, correct?
Yes,
Okay. And you described for counsel the examination you conducted. You knew from the mother that there was thought to be a psychogenic component to the patient's pain. Is that right?
by history, correct.
Okay. And you knew that the patient had been seen at Tampa General Hospital?
Yes,
You indicated that you were familiar with the program there.
yes.
You know the doctors involved with it?
That I'm not so sure of. I'm not so sure.
Well,
In fact, I'd have to say probably not. I remember looking at those records, and I don't think I recognize any of those names.
well, you didn't see the Tampa General records before you did your examination and diagnosis on September 23rd, did you?
Probably not. No.
As a matter of fact, you told the mother you didn't want to see it. Is that right?
No, that's not correct.
That's not correct?
Jerry.
No, it's not correct.
Okay, we'll get back to that in a second. But in any event, you didn't speak with any of the doctors at Tampa General, did you?
No,
And you knew that the patient had been seen at Lurie Children's Hospital, correct?
correct.
You knew Lurie's was a pediatric hospital?
Correct.
You never spoke with any of the physicians there, did you?
Correct.
And did you ever speak with a Dr. Wyndham regarding the patient's immunodeficiency status?
I don't recall that.
Well, you were told that the patient had selective immunodeficiency, weren't you?
Yes.
I would just like to point out that he did say in his testimony when he was with Anderson that he wanted to go in as unbiased as possible in his evaluation of Maya. So that could be why he didn't look at all the records, because he didn't want to be swayed. Just like, who was the other good doctor who said that? Oh, yeah, Dr. Chopra. Mm-hmm.
But did you talk to the allergist or the immunologist who diagnosed it?
I don't recall that.
Did you talk to Dr. Kreisman at any point?
No,
Did you talk to Dr. Wasnauer, the patient's general practitioner?
I don't think so.
Were you aware at the time that you made the diagnosis of CRPS in this patient, that this patient had seen over 36 other physicians about her pain and condition?
I don't know the exact number.
You knew it was a good many, didn't you?
Yes, sir.
Did you talk to any one of them?
Well, I don't remember the list. I mean, so I don't recall that. I don't recall talking.
You had a patient in front of you who literally dozens of other doctors had seen and treated at length.
It really
You were
doesn't
the
mean
first
anything.
one making a diagnosis of CRPS, correct?
Correct.
Because he's an expert. He's a specialist. And oh my
You're the
God.
Lone Ranger.
You're the Lone Ranger. Listen to this. You're the Lone Ranger. Objection. Argumentative. Hostile. Objection bullshit. You're the Lone Ranger. He's not the only, look at his face. He's not the only person, the only doctor who specializes in ketamine treatment for CRPS. We already heard from Dr. Chopra, but there aren't that many of them because this is a very specialized field, right? Why would he have to talk to her asthma doctor when he's trying to get down to the root of the pain? It's clearly not asthma.
You're the first one that came up with that.
Correct.
Did you call any one of those
He's like, yep, and I was right.
doctors and attempt to reconcile your diagnosis with all the other diagnoses that had been made regarding this patient?
No.
Why would he call the doctors who were wrong? Why didn't you tell me, doctor, why didn't you call all the other physicians who couldn't do their jobs properly and diagnose this child? Why didn't you call them for their opinion? Because they were wrong? I don't know.
Incidentally, you were the first one to diagnose CRPS
Yes, sir.
on September 23rd, 2015.
Yes, sir.
How do you suppose it was that the mother thought that was the current diagnosis a week before?
Because
On
she met
September
people.
16th, 2015.
Before she saw me on the 23rd of September?
Yes, sir.
I'm not aware of that.
probably because she found people with kids with the same symptoms and they had CRPS and she was starting to research it herself. Do you know how often I have diagnosed my kids first before the doctor has? Do you know how often? Almost every time. And luckily, I have a doctor who listens to me. When I say to him, I don't really think that this is a virus. I actually think it's bacterial. I think it should be checked, and I think she needs antibiotics. He listens to me. And 9 times out of 10, they need the antibiotics. Mothers are very good, especially when you've been a mom for a while, at recognizing what's going on with your kids. Now, for a complex, very rare disease, you're going to be the type of parent who is researching these symptoms, and you're going to be looking at all the possibilities. And so you're going to have a list of possibilities that you're going to think it could be this, it could be this. That's how I think could be this. So I bet Beata had a list of things, and CRPS was on it, and she had met that support group. So it's not. Is he really trying to say that Beata somehow talked this man into believing that her daughter had CRPS, but she didn't? Come on.
Well, could we put up Joint Exhibit 2012, 25 and 26, please? Yes. Joint Exhibit. My copy says Joint Exhibit at the bottom.
The 2000 series is not joint.
I beg your pardon. I said 2000, 1000. This is 1012-0025. I beg your pardon. Sorry.
I don't think Maya was in the courtroom yesterday. We've seen no camera angles of her, so I hope she's doing okay.
I'm not sure whether that's 2000, 1012. Okay, well, if you look at the end of the second paragraph on that page, up one, reflex sympathetic dystrophy is the most current diagnosis.
What's the date on that, Counselor?
The date on this is September 16th, 2015. Part of the records of Dr. Kreisman. Have any idea where Dr. Kreisman would have gotten that history other than from the mother?
Where's the date on this document,
If
Counselor?
you go to the first page of it,
Please.
1012-25, you do side by side. You look, date of visit, September 16th, 2015.
Somebody's blocking my, I'm trying to read this and they're blocking my view.
Beg your pardon.
Thank you.
Date of visit.
I'm just trying to see how I'm just trying to read the document. So this is page 2. Or what page is it? No, I'm sorry. Page 26 and 28. If we have time, I'd like to read this.
You go back to the first page, please. Can you make it larger, just the first page?
Yeah, thank you. That would be helpful. Yep.
Well, it's a pulmonary note, doctor, so I'm not trying to belabor what the pulmonologist's findings were, although I want to ask you whether you ever talked to him.
Mr. Hunter, you wanted to look at the document to answer your prior
that's
question.
fine.
Yeah. Can we scroll up a little bit, please? Thank you. Okay, scroll up a little bit more, please. More, please.
You want the next page?
Well, it's
Or you want the top of page 1?
I'm reading it. So go down. So I'm looking at page 25 of 28. Can I see that whole page? I'm seeing part of it here. I'm still seeing part of it here. I don't see the whole.
I think you need to go to the next page.
The next page, please. So this will be the next page. Am I correct on that?
You are correct.
Thank you, sir.
Let me see if I can read this. I can read some of it. It says she has been seen by numerous specialists, including rheumatology, maybe neurology, psychiatry. This is very blurry, but I'm trying. Something, endocrinology, I don't know what that says. Physical therapy and speech pathology. Other diagnoses that have been mentioned include sinus infection, allergic rhinitis, pertussis, reflux, what is urinal and no, I don't know what that says. Something dysfunction, psychogenic something. Psychogenic cough, foreign, I don't know what that says. It's too blurry. Cystic fibrosis. Laboratory studies have included evaluation for Lyme disease, which was not conclusive. There is a something from the mother. There is a concern from the mother that the child has selective immunodeficiency. Reflex sympathetic dystrophy is the most current diagnosis. The development, adrenal insufficiency, and steroid-induced something after past treatment with high-dose steroids. And then there's a big list of things. Current medication list includes, and there's like 11 different medications, which a bunch of them are over-the-counter. Claritin, Flonase. They've got her on Prozac, Benadryl. I can't read all of these. It's too blurry. Okay, let's see. Should also break through with in some cough or wheeze. She gets 3 to 4 puffs of albuterol, Benadryl, something I can't read, and something else in something order. I'm sorry. I wish this was not as blurry as it is, you guys. I can only read every other word. Social history. Mother is a nurse. Father is a retired deputy. They used to live in somewhere, Chicago, Elmhurst, Chicago, until about a year ago. The child joined 3rd grade here and is now attempting to go to 4th grade. The family is in therapy to help deal with her pain issues. Has 4-year-old sibling Kyle, has a lot of difficulty dealing with her disease. She does not wish to go to therapy herself. Physical examination. I can't read the numbers there for her weight and height. Oxygen saturation, 96%. On room air, she is examined in her wheelchair where she, I don't know, something, and cries, where she moans and cries continuously. I was something to distract her and engage her in conversation. She became alert. No, wait. She became, I can't read that word. Something and complexity. Different child, or completely different child, with a smile on her face and fairly lively interaction to the conversation. So they're saying that she somehow, after being distracted with conversation, she cheered up, I guess.
Oh, here we go. Okay, this is what I was looking for. So the sentence reads, there is a concern from the mother that the child has selective immunodeficiency. And then the next sentence reads, reflex sympathetic is the most current diagnosis.
Right.
So, but it's not, he's making the diagnosis. He's just saying that that's what, I don't know. I don't understand it. It doesn't make any sense. There's nothing to back up what he's saying. So I don't know.
Okay. But point is, you wouldn't know where he would have gotten that history the week before you made the diagnosis.
I don't know where it came from, sir.
All right. Now, as a result of your visit on the 23rd of September, you recommended that this patient undergo your ketamine infusion therapy 4 days in a row, correct?
Can we bring up that record so I can see what you're referencing? I mean, there's more to it than just what you just said. I'd like to see what you're making reference to. It's not. Could you bring it up so I can see it, please?
What record do you want me to bring up?
You're saying I went from this to that.
No, what I'm saying is, what I'm asking you is, as a result of your visit with this patient on September 23rd, 2015, in which you diagnosed CRPS, did you make a recommendation that the patient undergo ketamine infusion therapy?
There may have been some other things included. That's my point. I'd like to see what else it says.
In that case, if you would bring up the doctor's September 23rd treatment note, which is Joint Exhibit 1056-001.
May we go down on the document, please? Scroll up. Thank
If we
you.
go over to page 2, we can talk about the recommendations you made
Okay.
at the bottom.
Okay.
You've told us that you.
Well, wait, I want to read it, Can you bring it up so I can read it?
Sure.
I want to see what I said. Okay. Okay.
Are these his records?
So what it says here, it doesn't talk about that, right? It talks about some physical activity, some heated pool exercises. That's the way it started.
Okay, I was going to back up and ask you. You told counsel that you wanted her to try heated pool exercises.
Correct.
And then you wanted the patient to be evaluated by a pediatric internist to determine if there's anything you can do to minimize the risk if you should elect to go forward with the four-day ketamine infusion, correct?
Correct.
Okay. Who was the pediatrician that you had clear her for that ketamine infusion therapy?
Anthony Kreisman.
You spoke with Dr. Kreisman?
No.
Did you ever see a report from Dr. Kreisman about that?
No.
How do you know he cleared her then?
Because I told the mother to go over the material, the basic question, is there anything else that he can do to minimize her risk for the procedure since she has a history of cough asthma?
Okay.
And that was the only question I wanted to know, that if there was anything that could be done to further reduce the risk.
Tell me when you heard from Dr. Kreisman that was the case.
Well, the first time I heard it was from the mother when she came back for an office visit with the child.
So the mother told you that she had gone back to see Dr. Kreisman and to discuss that with him.
Correct.
When did you have her seen by a psychologist?
I did not do that as far as I can recall.
Isn't that something you usually do with patients that you refer to Dr. Cantu?
No.
Isn't that on your website as something that you usually do with patients that you send to Dr. Cantu?
No.
Now, ultimately, you did go forward with the ketamine infusions, right?
Yes. Now, sir, be clear. You're talking now about the conscious sedation, or now you moving over to the ketamine coma procedure? Where are you now?
No, I'm talking about what you did.
What I did. Okay, no, that's fine.
You never did a ketamine coma, did you?
I've done it before, sure.
But you didn't do it on her, did you?
No, I did not.
You did that in Mexico, correct?
Correct, and I've done it at Tampa General Hospital.
Okay, and you don't do it there anymore, do you?
Correct.
You're not a member of the medical staff there and haven't been for about 10 years, correct?
I'm not sure it's 10 years, but I haven't been there in a while.
Okay. And they haven't been doing that in a while, have they?
No, I don't think so.
The when you talk to your patients about this ketamine infusion, I'm going to call it ketamine infusion therapy. Okay? Is that right?
Can we say conscious versus general anesthetic?
Okay, I'll
please?
call it
There you go. There you go. He's controlling the lawyer now.
conscious sedation therapy.
Thank you.
Okay. And incidentally,
He's funny.
You want the patient conscious to avoid risk to the patient's airway, correct?
Correct.
Okay. And if you were giving high doses, anesthetic doses, you would want the patient to be intubated to protect her airway, correct?
If the patient was being anesthetized in general anesthesia, yes. Okay. Otherwise, don't give me the dose thing, because the dose, some patients require the different doses. You have to tailor the dose to the patient's needs.
We're going to come back to that. Let's talk about the.
I was listening to Rob yesterday on this lawn lumber, and he goes, whenever the hunter says we're going to come back to that, notice how he never does. It's like, if you had, the way he explained it was, if you had the receipts to show that you could discredit him somehow, you would do it right then. You would not say, we're going to come back to that. And then watch, because he won't come back to it. It's just a way to get out of it, making the jury believe he has something when he doesn't. And I don't know why that's allowed.
Warnings, the information that you give your patients before ketamine infusion conscious sedation. Okay?
Okay.
You tell them, and we can bring up his consent form if you wish. Joint Exhibit 1056, 0158, and 0159. I'm going to cut to 0159 and ask whether you tell your patients, told the Kowalskis you didn't know if the therapy with IV ketamine will help alleviate the symptoms of CRPS in every patient long-term.
Correct.
And you basically tell them in the next paragraph that the more you treat patients with IV ketamine, the more you'll learn about it, correct?
Correct.
And then you warn them that they might have problems from it, correct?
Correct.
And those include infections, correct?
Correct.
Gastrointestinal imbalance.
Where are you reading, sir? I'm looking at the document here.
I'm reading the third bullet point up from the bottom of the page. Gastrointestinal imbalance and or discomfort and muscle weakness due to ketamine.
Yes.
And then you warn them about loss of weight.
Yeah, has anybody seen the list of side effects?
And you've talked to us about this.
The list of side effects on any drug. Some of the most popular ones have a side effect that always makes me laugh of anal leakage. Like, yeah, that sounds like something I want to take. Yeah, no, thank you. Every time Big Pharma has their pills out on commercials, they have to go through a list of may experience nausea, vomiting, anal leakage, and it goes on for like 5 minutes. This should not make anyone feel any kind of way about anything, because every drug has a list of side effects like this as long as your arm.
You've warned them about temporary loss of memory.
Yes. Is this the next page now we're looking at?
Yes.
Thank you.
Okay. So with all that, these folks elected to proceed, correct?
Yes, with conscious sedation. Correct.
Okay. Now, I want to make sure
Yeah, we'll come back to that. Really means I won't be coming back to that. You got me. That's what it means. We will not be coming back to that because you didn't answer it the way I wanted you to.
Understand how much you gave them. And I ask that Joint Exhibit 1055, 008, and 009 be put up. You can put those up side by side and highlight the total ketamine at the bottom of this page. That indicates you gave a total of 137 milligrams?
That's what it says, yes.
Is that correct?
Yes.
And then if we go to the next page, next infusion, which was the next day, 1055, 0012, 011, and 13, we see that you gave 215 milligrams that day, correct?
I don't see anything here, sir.
Oh, I'm faster than my guy, sorry.
Do you guys remember the potato chips that were made with some kind of new oil that was supposed to not be fattening? And they gave everyone the shits. Do you remember? And there were people who were like, well, but it's not fattening. So what were those? Remember they were potato chips that taste just like regular potato chips, but they would give you the runs. Olestra. That was a funny moment in time. Where people were choosing the shits over gaining a few pounds.
If you look at the bottom of 2013, if you'll scroll up someplace on the right-hand side, I thought.
Speaking of gaining a few pounds, we've been sitting here for a really long time and we have not moved. We have not gotten our circulation going, which is a real problem. And that's not allowed here on this channel. We need some fat shaming. I'm going to call on Nick Ricada to get in here and fat shame us while we do some squats. You got 1 minute and 22 seconds, folks. Get up, get out of your chair, start moving, do your squats. Let's go.
You impose fatness on you. You did it by going, oh, I want the butter on the popcorn. Oh, I want the butter on the ice cream. Oh, I want the butter on the sandwich. Oh, I want the butter on the salad. Stop eating butter. Can you just get up, walk 1 mile? Do squat! Walk farther. And if you can't walk, crawl, roll, get dragged by a goddamn forklift. Whatever is wrong with you, just move. Ever. Get off the chair. Get off the couch. No one is coming to service you while you sink into that furniture, while you become one with the pleather your poor ass got on that Walmart couch. Can you try not floating into sadness? Stop eating, stop drinking, start walking, start doing anything that you haven't been doing, you fat piece of shit.
All right. That's better. That's better. Okay. The blood is moving and we're back. All right. So AP says, yes, there was a lady at my work that didn't quite make it to the restroom across the aisle from her desk because of those chips. Oh my gosh, you guys. This was really a thing. This was really a thing. Potato chips that made you get the squirts, and people were choosing the chips, which totally made me confused. I would not choose that. Nope. No, thank you. All right. Here we go. It's back at it.
So in 2012, I'm sorry, you got 2013, excuse me, 11, I beg your pardon. You've got Joint Exhibit 105513, it should be 105512. Is that correct?
I see it now. Yes, sir. I don't see the date, but I see the number.
Okay. Then if we switch to 10-8 and we go to Joint Exhibit 105514 and 15, we see that the total ketamine given on the third day is 255, correct?
I see that. Yes, sir.
And then on the fourth day, 10-9, October 9th, we look at 1055, 17, and 18. We see that the last dosage was 300 milligrams, correct?
Yes.
Now, you consider those as high a dose as you wanted to give this patient, correct?
Yes.
And she stayed conscious during this, correct?
Yes.
And you charged the family a total of $10,000 for 4 days of the treatment?
Yes. Well, plus the follow-up. We don't charge them for coming back and being reevaluated and repeating all the measurements that we did on them, including the videos and so forth. Follow-up, strength and range of motion, pain thresholds, and so forth. That's all included. Everything's included. It's not just the 4 day.
So you did an assessment of the patient after that on October 13th?
Correct. That would be probably the following week.
And you said at that point that she showed improved post-treatment pain threshold associated with slight improvement in strength and range of motion, especially in the upper extremities.
I don't see that report here, but what you're saying sounds reasonable. But I mean, if you want, I can confirm that for you.
I'll put it up. It's Joint Exhibit 1055-22. So, would you have done a video this day?
Let me think. Okay, so the answer is probably yes.
Okay. But in any event, the improvement was slight and the patient was still wheelchair bound?
Yes.
Still couldn't walk?
Yes.
Still had allodonia?
Yes.
Still had dystonia?
Yes.
Still had limitation of motion?
Yes.
Really didn't have any functional improvement, correct?
Well, the way I worded it was just slight. We have a video recording of this, and if I recall correctly, I believe I commented on the video that that there was some slight improvement. I believe I'm best I can recollect, in the foot on the left side.
Okay. So the records we have suggest that you next saw the patient on September 2nd. Excuse me, I'm sorry. I beg your pardon. November 2nd of 2015. That sound correct? And I'll ask that Joint Exhibit 1055-32 be put up for the doctor's benefit.
Okay.
Now, when she came in this day, it was billed as a return patient evaluation, correct?
Yes.
And when she's in your office that day, she's complaining of increasing CRPS pain in her legs, correct?
Correct.
And she was unable to intake adequate fluids and food?
Correct.
She appeared dehydrated?
Correct.
And with that dehydration, even with that dehydration, you were unable to carry out blood pressure monitoring secondary to pain, even with a manual cuff, correct?
Correct.
So you said you noted that she had a reasonable peripheral pulse for a 10-year-old, but you weren't able to assess her blood pressure, correct?
Well, there is a statement, reasonable peripheral pulses with it for a 10-year-old. For a child that age, she had blood pressure. I mean, she didn't have, sometimes you see enough kids, you just know that if you were able to get a blood pressure, you were going to get a reasonable blood pressure out of that.
It's always good to have a blood pressure.
No, well, I wouldn't go, I wouldn't say that. If you got a patient talking to you, I don't get blood pressures on it necessarily.
But she's dehydrated.
Yeah.
And you can't get the blood pressure.
She had it says
you were concerned about the dehydration, weren't you?
Yeah, yeah.
And as a matter of fact, both the mother and the child were expressing to you suicidal ideations, correct?
I don't see this in this report.
Well, didn't you testify to that?
I don't think so.
No,
on this
he
date,
said he didn't. He said he doesn't remember that. He said he did not remember that the last time you asked him, Hunter.
Before we go to that, can we agree that at this point
We'll
you
come
thought
back
this
to that.
child's CRPS, which you had, incidentally, didn't you rate this child's CRPS disability as severe on your first visit?
I believe so. Yes, but to factually state that, I would like to see my report, but I'm almost sure that I did. Just thinking about it.
In this report, you indicated that the CRPS she had was intractable, correct?
Correct.
And it had proven refractory to your first care, correct?
Yeah, very poor response.
Okay. And so let's talk about the problems that the patients were encountering. I'll refer you to page 142 of your deposition.
I'll trade you. This is yours.
Oh, okay. Thank you.
I'm sorry, which page, sir, would you like me to go to?
Well, I was going to go to page 142.
142.
Where you testified as follows. I asked you, but she was able to be touched during the previous infusions. A, yeah, before, yeah. This patient has deteriorated in this situation to the point it's a life-threatening situation, both from a physical standpoint, hemodynamic standpoint, and from the standpoint of emotionally suicidal. And you could not get vital signs that day. Is that correct?
No, that's not what. Did you take any vital signs on that date, doctor? Answer. Well, I tried. I mean, remember, I said I couldn't get a blood pressure cuff on her, and we just read here where I was able to get our normal pulses on her.
Okay, but the complete set of vital signs includes blood pressure, right?
Yes, it would.
And your history indicated that she was unable to take fluids, correct?
Yes.
So she's dehydrated, and you have no way to rule out that that's not going to get worse, correct? If she's not taking fluids.
Well, if you read the rest of this, it talks about getting an IV, getting IV access established. Okay, and that was the idea. Get an IV in, because the problem is that I'm trying to remember. This is yeah, I think this was the time we thought that talking to the mother and so forth, that it would be a good idea to have IV access. I think at this point, if I remember correctly, they were thinking about going to. Well, let's say I don't know. I don't remember exactly the context of this.
Well, that's what I was going to ask you about, because you didn't make a referral to an emergency room that day, did you?
No.
And you didn't make a referral to a psychologist that day, did you?
No.
And you didn't really do anything to give her fluids, did you? You yourself, did you give her fluids?
No, we talked about starting an IV on her.
You also started talking about placing a PICC line, correct?
I can't remember if that was the day we had that discussion or not.
Well, was that the day that you wrote her a prescription for a PICC line?
It's possible. Again, I have to check the dates of this report, but it's possible that was something that I thought would be a good idea. And
okay, well,
I'm trying to put this in the total perspective of what was going on at the time in terms of the mother contacting Dr. Cantu and there's a lot of moving parts here. Okay. And I'm trying to put it all together in my head as we're sitting here.
Incidentally, well, I'm going to ask Clay to put up 1056-211, but let me ask you a question. You've indicated a couple of times concern about pulmonary embolus, correct?
Correct.
Isn't dehydration a risk for pulmonary embolus?
Yeah, I suppose you could argue that, but that's a stretch. That's a stretch.
If you put up 211, you've written a prescription here for a patient with poor IV access requiring chronic treatment of CRPS with IV ketamine requires a 2-lumen line placement for immediate fluid replacement. Is that right?
Yes, sir.
And then you wrote her a script for IV to be administered by the mother, correct?
Sir, do you mind putting that up, please?
We'll find it in just a moment. Do exactly that.
Thank you.
How about 1056-212?
My standing desk. I'll be right back after I readjust here.
Got it. Okay, thank you.
Patient currently dehydrated with poor nutrition requires fluid with normal saline, 500 milliliters now QD-PRN. In other words, each day as needed, correct?
Yes.
Something electrolyte, something weekly. Check electrolytes weekly, is that
Yes.
right?
Yes, sir.
So you envision the mother giving this IV to the daughter herself, correct?
I believe that is correct. She's an infusionist. That's correct. I believe so. Again, I'm trying to recall the details here.
And then subsequently, there was concern about the patient's level of pain, correct?
I don't know. What are you referring to?
Well, I'm having reference to a prescription that you appear to have written, put up. Can I show you that? I'm going to have to show you that, so I'm not sure this is in evidence. Is 304301 in evidence?
Can we see it? Yeah, is that in evidence?
Yeah, we're sidebarring again. Well, so far I think he's doing okay. I kind of spaced out in the last couple of minutes. I'm not sure what all this is about. I don't know. I mean, he's trying to discredit him by saying, well, you reported that she was dehydrated, but then you took no steps to hydrate her. So you are a strip mall doctor, aren't you? Since you did not get her rehydrated immediately. Well, she lived, so I don't know how effective this is. She came to no harm. I don't know what they're arguing about, but that hair island really needs to go. Really needs to go. Yeah. Move the F on. Exactly. Let me go over to Rumble. Hey guys on Rumble. Thanks for being here, by the way. Let me check out the chat on Rumble. By the way, Crazy Warlock needs to get some credit for thinking of olestra before I did. When I was talking about side effects, I wasn't looking at the Rumble chat. And he brought up olestra and the chips. And then I brought it up totally independent of that. And I went over to check the Rumble chat. And I'm like, you just brought up olestra before I did, didn't you? It's funny how we're all on the same wavelength. We think alike, great minds and all that. By the way, if you are watching on Rumble, don't forget to hit that thumbs up. And if you're watching on YouTube, don't forget to subscribe and subscribe on Rumble as well. I don't know what we're at on Rumble as to, we're at 4,500 followers on Rumble. And I am almost at 19,500 on YouTube. You know, before they screwed with me and shut the demonetization down, we were climbing towards 20,000 really quickly. And then I lost a bunch of subscribers when they took down the monetization. So hit the subscribe if you like the channel and you're going to watch the show. Jillian took some time to go and Google olestra chips. Yeah, it was a real thing. And the commercials for it were hysterical. I wonder if we could find one on YouTube. The commercials for it were like, could cause anal leakage. And we were like, what? Why would anybody eat chips knowing it could cause anal leakage? And then, yeah, people were like shitting their pants. It was bizarre. And people continued to eat these chips. I think they took them off the market eventually. Medium smart minds. Thank you, Crazy Warlock. So far today, I think I've earned $15 an hour. Yay me. Actually, less than that. It's been 2 hours. $6.50 an hour, maybe $7.50. That's not bad for 1985.
I'm sorry.
Don't worry about me, folks. I'll be fine. I'll just work some extra shifts at the restaurant. Mm-hmm. Which actually, my schedule's been cut way back.
After this,
because it's the slow
wound
season.
up referring this patient down to Dr. Cantu, as you described.
Yes.
And at that point, she came back to you for a follow-up visit, correct?
Yes.
And you saw her in January of that year, is that right?
I believe so, yes.
Now, you then have told us you lateraled the ball, if you will, to Dr. Hannah?
Yes.
And I saw no notation in your note that you kept up with her after that. Is that true?
I'm just trying to reflect on that. I don't recall her coming in for an office visit. That was the reason why I had wrote a note the day before Sally Smith. I called Sally Smith. And so I hadn't seen her in a while, so I wanted her to come in and see how she's doing.
Okay. And the reason you wanted her to come in and see how she was doing was that when you heard about Dr. Smith, you had not seen this patient since January, correct?
No, that's not the sequence, counselor. The sequence is not knowing anything about any problems with Johns Hopkins, without any knowledge of any of that. I just thought, well, listen, I haven't seen this child in a while. She's, 9 months or so, or maybe less than that. And I thought it would be a good idea to have her back. So I wrote an email to the mother saying, how is she?
I understand. You did that in October of 2016, correct?
Yeah, before I knew anything about Johns Hopkins, just because I was interested in seeing how she's doing. Yeah.
I understand that. You did that before you knew anything about Johns Hopkins. You had written an email to the mother to ask her to come in, correct?
Yeah, I wanted to evaluate the child.
And then you hadn't seen the child by the time you spoke with Dr. Smith, correct?
Correct. Other than when she came back from Monterey. Yes.
Okay.
That's correct.
So, excuse me, can I help you also? Sorry. So the point is that when you talked to Dr. Smith, you had not seen or evaluated this child since January of 2016 when you saw her after she came back from Monterey, correct?
Correct.
Okay. And you hadn't spoken to Dr. Barr about his treatment of her, correct?
I believe it was he the hyperbaric person. I'm trying to remember the names.
No, Dr. Spiegel was the hyperbaric.
Was it? Okay.
Had you spoken with him?
No, I haven't.
And you knew nothing about hyperbaric therapy, did you?
It's kind of vague in my mind. I don't think so.
And you didn't recommend it, did you?
No.
And you never prescribed any further ketamine for the patient in 2016 after January, did you?
No, she was being seen by Dr. Hannah.
Dr. Hannah. So you may have had some emails with mom about the patient, but you hadn't had any contact with her between October and January, correct?
I don't recall.
Did you ever speak with Dr. Hannah and learn from him that his treatment of the patient had failed?
No, I never heard that.
Did you ever see the patient in October 2016?
I couldn't. She was taken. I don't say taken. She was admitted to the hospital.
Between October of 2016.
Yeah, she was taken all right.
October 7th, 2016.
Okay.
Between that date and January 1st of 2016, January 6th of 2016, you never saw this patient, correct?
Correct.
All right. Now, if I ask you to assume that as of October 7th, this child was in a wheelchair, could not walk, had pain, allodynia in her lower extremities, had dystonia, was not in school, and was basically in that level of function, would I be describing the child as you saw her on September the 23rd, 2015?
No,
Why?
because as you noted, she had seen, Dr. Anthony Kreisman had seen her before she went to Monterey, saw her afterward, and said, this child is totally different. No pain.
No, sir. I'm not asking about when Dr. Kreisman saw her.
No, I'm talking about what was being reported, her care under Dr. Hanna. I think that was the
understand
question.
Sir. What I asked you was this. If you assume for the sake of my question that her condition was as I described it on October 7th, 2016, my question was, would she be in essentially the same condition as she was when you saw her, not Dr. Kreisman, when you saw her on September 23rd, 2015?
Based on the information that I have available, she was doing a heck of a lot better.
In what respect?
Well, you read the reports from people that saw her during that time frame.
No, sir. I'm not asking about what happened during the time frame. We'll stipulate that there were ups and downs. What I'm asking you is that in net effect, from September 23rd, 2015 to October 7th, 2016, was there any net change in this child's condition?
From the time I initially saw her, let me see here, I get your question right. From the time I first saw her on September 23rd, you're asking me what now? I'm trying to understand your question.
My question is, when you saw her on September 23rd, 2015,
First visit.
She had dystonia, correct?
Yes.
She's wheelchair bound.
Yes.
She can't walk. She's non-weight bearing.
Yes.
She doesn't have good function and movement in her upper extremities.
Yes.
She's not in school.
Yes.
She can't take care of her own activities, daily living, correct?
Well, that I don't know if I agree with.
Everything else we agree on, right?
Well, I don't know. You're asking me to lunk a whole bunch of stuff together.
Well, I'm asking you what your examination revealed, sir.
You gotta let him answer.
Isn't that what you found in your examination of that patient on September 23rd, 2015?
I saw the patient. Again, I'm trying to get the time frame in my head. You're saying from the way her function was when I saw her initially, compared with what?
Compared with October 7th, 2016.
October 2nd.
7th.
That's the day she had a relapse. Ended up in the morning at Johns Hopkins.
It's the day, several days after her relapse, and she did wind up at the hospital that morning. I'm describing to you her presentation to the hospital versus her presentation to you on September 23rd, 2015.
Okay, I think I got it. Okay, so she has a relapse and ends up at Johns Hopkins with a stomach ache and a recent injury to her foot, and looks like she's got an exacerbation of her CRPS. If that's your question, I would say she was in worse shape than when she entered the hospital. She was having a crisis. She was having acute injuries to her abdomen, acute injury to her foot. That's not what I saw when I saw her. And that's not what I saw. So that particular occasion, when she was being admitted, she was worse off when she was being admitted because of some events that took place suddenly. And that happens to be the stomach ache, the injured foot, acute injury to the foot, as well as having her CRPS probably exacerbated by the acute injury she was having, which includes the stomach ache and the injured foot.
What acute injury to her stomach did she have?
Well, it said she had, she complained of stomach ache. From my understanding from the hospital records that I read, she came in a kind of a fetal position. And
did you review the entire hospital record?
Yes.
Mr. Hunter, you gotta let him finish his answer.
Yes, sir.
Were you finished with the prior question?
Well, I hope I answered the question. She, at that moment in time when she was admitted, she was in worse shape than it was when I first saw her on September 23rd, 2015.
You talked about telling Sally Smith about Munchausen by proxy, correct?
When you say telling her about it,
well, let me rephrase the question. That was a bad question. You talked about warning her not to pursue that, correct?
I did.
But you weren't surprised that she brought that up, were you?
In the beginning of the conversation, yes, I was surprised.
Didn't you warn Mr. and Mrs. Kowalski that they might be suspected of Munchausen by proxy the first time you met with them on September 23rd, 2015?
I don't recall that.
You're not saying you didn't, you just don't recall, right?
I don't recall.
And if I understand correctly, you did send this mother an email in the early hospitalization of her daughter, correct?
Yes.
And you did tell her in that email, and instantly, this is after she knew that there was an investigation going on, correct?
The mother?
Yeah.
Yeah, okay.
Okay.
Let's, yes, I don't, yes, I would assume so, yes.
Well, you knew she was very upset.
Yes.
And you told her at that time that if your treatment wasn't adopted, her daughter would die a slow and painful death within reasonable medical certainty.
Would you like me to look at the entire communication I had with her at that time?
I would be happy to show you the email that you sent her at that time.
Thank you.
Ugh, what a condescending prick this guy is. I'm sorry, I just had to say that. I would be happy to show you the communication. Like, just hand it over.
I wanted to find it.
Well, Boosh, I think he does have a soul, but he is a corporate attorney, and they do bad things. And that doesn't mean he's not a human being who loves his family and can be a nice guy to hang out with when this is his job. I mean, his job. Look, we all love Steve Gosney, and he has defended the worst of the worst. And we know Steve has a soul. We know that Steve is a good guy. And, he's defended child molesters because everybody deserves a defense. And so he's doing the best job he can. I just think he's coming across as being a condescending prick. It's just, if I'm on the jury, that's what I'm seeing. I think he's being a condescending prick. But maybe they don't see that. Maybe they see something else. But, he's probably still a decent guy to his friends. And who would blame him, by the way? Who would blame any attorney for working for big corporations? They get paid huge bucks. And in today's economy, chicken's expensive, man. Oh, he's done. He's done. He takes the money where you can get it.
I'd like to publish 2698. For the record, this is mine from August 11th, 2016.
First off, is this an evidence?
It is an evidence. Go ahead. 2698. And doctor, I'd ask you to review this. I'll have questions after. This is August 2016.
You guys notice how she wasn't using her feet to put any weight on them? And she did not stand up on the side of the pool. She scooched onto the thing. Wow, that sound is really bad. I got to cut that out because it's hurting my ears. We don't need to hear it. I think the defense is trying to show that she's perfectly fine. Well, I didn't see her put any weight on her feet. She got out of the pool and she scooched onto that thing and didn't put any weight on her feet.
Doctor, the child you saw, September 23rd, 2015. Could that child that you saw then do all that she could do in August of 2016? Move that freely, appear that devoid of pain, move with that joy when you saw her in September?
Not that joyful, especially she was not very joyful that I saw her back in September.
And between that and October 7th, Maya go into a fairly severe relapse where much of the progress over the intervening spring and summer was lost, at least for a while.
I'm sorry, would you repeat the question?
Sure.
Yeah, because nobody can understand your questions, Anderson.
during the child, strike it. Are you aware that in September of 2016, Maya had a severe relapse of symptoms of CRPS? First,
Oh,
Just
Anderson.
before
the October 7th admission.
Right. Well, yeah, I was aware of it just before. Correct.
And was that the reason why she looked like she did when you first saw her?
Well, at the time of admission
Yes.
on October 7th?
Yes.
Yeah, she looked worse. She was in crisis, yeah.
But immediately before that relapse, the child looking like she did in the last exhibit, was that progress, significant progress?
Oh, of course. She's a whole new human being, yeah.
Now, as to the who diagnosed first, was it your understanding that she saw or heard from her own patient, Dr. Daniels, that his daughter had RSD, and maybe Beata should check that out?
Understand his questions. I can't even understand them. The way he talks makes
can
it
answer.
unintelligible.
I heard something about that, and I don't know yes, I heard something along those lines, yeah.
When Beata Kowalski came to you, had she already been told there was a possibility of
Yes.
RSD?
Yes.
So this is not about diagnosing her. This is simply about whether she knew the phrase RSD.
Correct.
Overruled. That's all. Oh. Oh, yeah. Thanks. You mentioned Dr. Kreisman at Johns Hopkins. Recall Dr. Kreisman?
Yes.
And you recall something about him seeing Maya after she came back from the trip to Mexico? Recall that,
Yes.
Doctor? And then can we publish 1024 and specifically 1827?
What is it?
I'm sorry. No, that's not right. It's
Ugh.
1024.
Of course it's not right.
0030.
Same question.
It's Dr. Kreisman's note from the.
It's a pulmonary. Doctor, you take a look at this and see if.
Dr. Honor, can we approach?
Let's take it down.
Oh, now they're going to go approach. I'm telling you, Anderson's mode of speaking makes it so hard to understand what he is saying. His delivery with the constant pausing in between words makes it almost impossible to understand what he's saying. So every time he asks a question, and then he has this stupid tendency to make every question compound. He has to ask 3 or 4 questions in one. You lose where you're at with him. I have not understood most of his questions. It is so distracting. It's terrible. How come no one tells him this? Yeah, his cadence is really bad, and it actually affects the listener's ability to hear and understand what he is saying. God, I've never seen anything like it. I've never seen a lawyer ask questions like this ever in my life, ever. It's maddening. All right, let's skip ahead here since I don't need to be waiting for this. Come on. How long are we gonna?
Let me continue, Mr. Anderson.
Oh, here we go.
Doctor, please read the.
Doctor looked like he
paragraph
dozed off there for a second.
Actually, the second one under physical examination.
It's the read to yourself. We're just not reading documents to the jury.
Second paragraph, physical exam. Okay, got it.
Please read it. Is that what you were referring to when you were talking about the
Oh,
impression
is that
of this
what you were
Johns
referring
Hopkins
to
Children's Hospital
when you were
doctor
talking about
of Maya
your
once
impressions?
she had come back from
Oh,
Yes.
I can't even with him. No, Examoon, he speaks like this to everyone.
Okay, let's take the record down.
To everyone. He cannot speak without pausing his
There's the
sentences
jury.
every few words. Well, Rob is he gives a lot of grace to a lot of lawyers. He's still a practicing lawyer, and there's a lot of stuff he doesn't want to say, probably. I can't speak for Rob, but I'm not under those ethics rules.
You know what I'm going to do.
And
Make sure you
I'm
give
gonna say
Nicole
it.
all of the notes. Did we get all of them? We're still
All right.
working on note.
They're going to.
Oh yeah, you can let Dr. Hannon go.
They're going to go through the jury questions now. But they actually are they going to do it in front of the jury or are they going to do it without the jury? Is the
Well,
question?
that's a very good question. That's
Oh yeah, you can let Dr. Hannon go. An amount of quote latitude end quote.
well, that's a very good question.
Wait,
An
back
amount of,
up.
quote.
Back up.
The first question.
There we go.
In simplest terms, is it safe to say, unlike an understood and highly researched illness that has almost a flow chart list of symptoms that lead to a diagnosis and treatment, is CRPS still being researched and therefore needs a certain amount of quote latitude end quote in both its symptoms, diagnoses, and its treatment to be allowed?
I'm trying to get my arms around that question a little bit.
Yeah, that's a tough question. What?
Well, I think perhaps the lawyers, I think, understand and will ask that question a little bit different way. So let me go to the next.
Don't count on Anderson for that.
And the jury said a simple no or yes will do.
What?
The designation of quote board certified end quote was brought up. Is board certified a designation that a doctor knows more, or is it better than a non-board certified doctor?
Well, that's a very good question. And that's to look at in terms of claims, malpractice claims, and all that sort of thing. You really can't tell them apart.
Oh my God. The fact that after that entire testimony, there's a juror hung up on being board certified. There is a juror who is completely swayed by the defense. And we saw this in yesterday's, earlier in this day testimony too. What a stupid ass question.
You know, so you have to remember though, my situation is one where I trained in anesthesiology over 40 years ago, and it's totally different now in terms of the residency requirements and so forth and so on. And the reason I maintain my academic status all the time, including right now, still academically working, is the PhD degree, because that's what you do. And you got, if you have that skill, you're marketable in the academic field, especially in pharmacology. I hope that answers the question.
Okay, Dr. Kirkpatrick, yeah. Let's just, the next question I think calls for a yes or no. So
Okay.
hopefully we can confine ourselves to a yes or no on this.
Oh, for fun.
You received a formal request from Dr. Sally Smith of Johns Hopkins All Children's Hospital for your records about Maya. Is that correct?
From her personally, no.
You stated you made a call to Dr. Sally Smith. Did you send the copies of the records to Dr. Smith?
No.
Did you review Maya's medical records before treating her?
Yes.
Okay. And members of the jury, again, if I'm not calling out the question that you sent, that means I can't ask that question. Next question. During Maya's infusions, you monitored her vital signs during the ketamine infusions. Were they within normal range for a child her age?
Yes.
Was that for all of the infusions given?
Yes.
What relation or role does CRPS play in diagnostic, or sorry, let me read it again. What relation or role does CRPS play in digestive issues?
What we know and what my experience dictates is that it does affect the GI tract. And the CRPS affects the sympathetic nervous system, which we say goes into the GI tract, innervates the GI tract. And it shouldn't surprise you that you can really end up with poor function of the GI tract, which includes constipation. And I've seen that many times in patients. And guess what? Ketamine helps that. It helps it big time.
Oh.
The next question is, does obstination have a direct connection to CRPS? And if so, describe the relationship.
Oh, I'm not sure. Other than what I just said about the sympathetic nervous system and its relationship to CRPS, I don't know what else I could add to that.
How many treatments had Maya undergone before you recommended the ketamine coma?
By me personally, is that the question?
Yes.
Okay. For me, it was the 4 ketamine infusions, not to mention my prescriptions, to aggressively involve her in heated pull exercises. I found over the decades that is the most important thing. and if I may, Your Honor, because it's too dangerous. When you have the kind of legs she had, you can re-injure yourself and set off the CRPS again. So lack of having buoyancy when you're in the water is very protective of avoiding a relapse.
Mr. Anderson, do you have any follow-up questions?
May I speak to counsel for about responding to one?
Yes, please do.
All right. Crazy Warlock on Rumble says board certified doesn't mean shit when you get the diagnosis wrong. That would have been a fun answer. Yeah, it's I'm saddened that the jury is stuck on that kind of garbage word games.
Members of the jury, do you have any follow-up questions?
Oh no, do they?
Did I say hand? Okay.
Yes.
May this witness be excused, or does he need to remain under subpoena?
He may be excused.
Remain under subpoena.
So what that means is it's possible you might have to be called back, but you are free to go today. So thank you very much for being here.
Okay, thank you.
Judge.
Oops.
Uh-oh.
Oh, yeah.
I apologize. You can hang there. Members of the jury, that is going to conclude our testimony for today. So I'm going to let you go. Do not discuss this case amongst yourselves. Do not do any.
Stays on the stand, though.
I'm not asking whether that is yours. I'll get to that.
They let the jury go.
I think Mr.
PCA 0.02 milligrams per page 1 of Defense Exhibit 3.
What is this about? All right, so they let the jury go, and now Hunter wants to ask the proffer, proffer the doctor some more about something. We don't know what yet. Let's speed this
Please
up.
be seated.
Oh, here we go.
Doctor, there's going to be a few more questions, but we had to do these outside the presence of the jury. So before I let you go, I think Mr. Hunter has a few more questions for you. Mr. Hunter, you have the floor.
I have 3 areas of question about Kirkpatrick. My first witness, Judge.
I'm sorry?
Yeah, first witness.
Yes.
I'm showing you page 1 of Defense Exhibit 3043. It's dated November 5th, 2015. And what I'd like to ask you is whether the signature at the bottom of the prescription for hydromorphone PCA 0.02 milligrams per milliliter, no basal rate, demand dose 0.05 mg, lockout 30 minutes, supply bags for 60 days, may titrate dose and lockout interval to max demand dose of 1.1 milligram, 0.1, I'm sorry, milligram with lockout 20 minutes based on patient response. Is that your signature on the prescription?
No,
That prescription is not yours?
it is not my prescription. I didn't write this down at the bottom of the page. Patient is terminally ill.
I understand that. I'm not asking that. I'm not asking whether that is yours. I'll get to that.
Okay.
What I'm asking you is the
Yes.
prescription here.
That's there. Yeah.
Is the signature on the script itself, not what's below it, but
Yeah.
the script itself,
Sure.
is that yours?
Yes, sir.
Okay. And you've told us before that the notation patient is terminally ill and whatever that is below that is not you.
Correct.
Okay. Then, but to be clear, the prescription itself for the hydromorphone PCA device was written by you.
Yeah, but the thing is, wasn't executed.
Right? Leaving that aside, that was you wrote the
Right.
script.
So the script is not valid. But anyway, yes,
But you wrote the script.
I wrote the script, but the script never got executed.
In other words, it got filled.
Never. Right.
That you know of.
Excuse me.
That you know of.
Yes, that's correct. As I know it. Yes.
Okay. All right. So I'm also going to hand you Defense Exhibit, page 54 of Defense Exhibit 3224. It's a sequence of emails, and I'm going to direct your attention to the one in the middle, dated November 10th, 2015 at 9:38 a.m. Anthony Kirkpatrick, MD, PhD, wrote, etc. It says it's addressed to Ms. Kowalski. Now, directing your attention to that email to Ms. Kowalski, it reads, today I received a request from pharmacist Jocelyn Krager requesting that I write a script stating that Maya is terminal. You said copy of that request is below. I am not willing to do that. It is beyond my scope of practice. And then it reads, on November 7th, 2015, I gave you what I believe is in Maya's best interest. Copy attached. Maya is 10 years old, and it's up to you as her mother to do what you believe is in her best interest. And the next paragraph goes on, I suggest you contact your local hospice care unit and determine if they have a palliative care program, and then it's signed by you. Did you send that email to Ms. Kowalski on November 10th, 2015?
I did.
And then finally, as far as we are concerned, at least, you indicated, I believe, in questioning that there was a request for records that you received regarding Maya Kowalski at or about the time you spoke with Sally Smith.
Correct.
Did that come from DCF?
I believe so, yes.
Okay. And that's the request to which you did not respond, correct?
Well, no, we did respond with
Oh, you
it.
did respond.
As far as I know, yeah. Oh,
I
yeah.
misunderstood your testimony. Okay, so you're telling me you got a request for medical records regarding Maya Kowalski, not from Dr. Smith, but from DCF.
Correct. That's my understanding,
Okay, and you complied with that request.
to the best of my knowledge.
Thank you, sir.
You're welcome.
Could I have it done?
Oh, sure.
I need to give you some stuff.
Mr. Anderson, do you have any questions?
Yes. Doctor, did it turn out that that terminal prescription was actually for the purpose of qualifying insurance requirements to qualify for coverage or hope for coverage of the ketamine and other medications for Maya?
I know.
What just happened? Oh no. StreamYard is doing it again, or my computer's shutting down again, you guys. So if I disappear, I'll be back. Looks like I've got the swirly whirly ring of death. I don't know if it'll come back or not, but shit. I really hate it that this keeps happening. I mean, we are right at the end here, but I am going to come back because stay tuned. I'm going to read to you an article about olestra chips to end the day. And it's so funny. It's called, "Wow, these chips just made me shit my pants." So I'm going to reboot and I'll be right back. So go do some squats or something. All right. All right. I'm back. We're in the last couple seconds, I think, of Anderson's questioning, and I don't know if we necessarily need to watch the rest of that. What do you guys think? Should we watch the rest or should we go straight to the olestra? The olestra article. Let's go to the olestra article because it's so funny. Did you guys hear me while I was frozen? Did you hear what I was planning on doing? I lost 40 of you. Why did you leave? I said I was coming back. You people have no stick-to-itiveness. How many of you stayed around on Rumble? Oh, good. Almost all of you are still here. All right, hold on. We're going over to the article about the olestra chips since this came up during the show today. There's a little moment in time that I will never forget. Okay, here we go. Wow. These chips just made me crap my pants. The olestra story. The fat substitute came with a warning label for loose stools, but Procter & Gamble wagered that Americans wanted to snack without weight gains more than they cared about underwear stains. Forget Thanksgiving. The most gluttonous day of the year is Super Bowl Sunday, where bowl after bowl and paper plate after paper plate is filled with finger food bacchanalia that would make even the mad genius responsible for the TGI Fridays appetizer selection blush, and certainly the ancient Romans. And so, all week leading up to game day, we'll be offering up our own menu of scientific investigations, origin stories, and majestic feats of snacking that not even the biggest sporting event of the year can top. Early in David Fincher's Fight Club, Tyler Durden, played by Brad Pitt, gives a monologue meant to channel the anxieties of millions of men. Listening to him is Edward Norton, whose character has just lost his apartment and everything he owns to a gas explosion. Murder, crime, poverty, these things don't concern me, Tyler says. What concerns me are celebrity magazines, television with 500 channels, some guy's name on my underwear, Rogaine, Viagra, Olestra. Fight Club came out in 1999, but the fat substitute olestra had dropped into American snacks a few years earlier and quickly came to symbolize all that was wrong with modern existence. Olestra, also known by its brand name Olean, had become shorthand for a nation that had lost its way. In 1997, Procter & Gamble was about to launch its new fat-free snack foods via Nabisco and Frito-Lay to see if Americans would munch on the chips fried in calorie-free olestra. They made Indianapolis their open-air testing ground. Nearly 500,000 samples of olestra fried fat-free versions of Pringles, Lay's, Ruffles, and Doritos were handed out. And the response was largely receptive. Receptive enough, in fact, that consumers were willing to overlook the required warning label that read, olestra may cause abdominal cramping and loose stools. Most people didn't even seem to mind the diarrhea. To that end, Matt Hale, a mechanic, told the New York Times, I had to lay off these for a while because they gave me diarrhea and loose stools, before adding, but I didn't think it was severe enough, so I couldn't buy them again. This sort of pro-diarrhea response gave P&G a needed boost of confidence that Americans, eager to snack without weight gains, would rush to embrace their new fat-free foods. Meanwhile, as soon as olestra received FDA approval, late-night talk show hosts and comics had a field day. On January 24th, 1996, the same day the FDA approved olestra for human consumption, David Letterman's top 10 list was dedicated to the fake fat. We can't tell you exactly how they make it, but we can say this. 10 monkeys go into a room and only 9 come out, Letterman joked. Later, he invited Chris Elliott to perform a taste test wherein Elliott ate regular fat from a container and then followed that up with a spatula of olestra. He didn't finish the bit before the olestra had evacuated his bowels. Oh my God, we have to watch this.
Why don't you get right to the testing there of the, I guess it's regular fat and then the new artificial
olestra,
fat.
I'm very excited about this because olestra, as you know, it evidently it works pretty much the same way as regular fat, but it has, I think, like half the calories.
Now, when I heard
no
the report,
salt.
they were talking about maybe some side effects. You know anything about side effects?
Yeah, no, I've read that too, that there are some rather odd side effects. I don't know much about that.
All right, so get right to the comparison there. This is regular cooking fat and olestra. Here we go.
So Jerry, you ready with? We're starting with the regular beef fat.
Okay.
Oh God, he's gonna eat that? Oh.
This is the olestra here?
This is the olestra.
Okay.
Dave.
Oh my God. No. Oh no.
Dave, I can't tell any difference.
Oh, that's good. Now, thank you, Chris. Can you tell about any of the side effects now? You notice anything?
No, I don't notice anything. The olestra went down very smooth and went down rather quickly.
Right.
And in fact, I would say it's still going down rather quickly, and it's still. Okay, now I'm olestra free.
Oh, great. Chris Elliott, ladies and gentlemen.
Gross. All right. Jay Leno, on the other hand, went full on scat humor, joking, when you're through with the Pringles, you might want to hang on to the can. Soon, olestra jokes were everywhere. The 2001 Futurama episode Bending in the Wind begins with a building being torn down by construction workers who unearth a relic that's 10 centuries old. Fry is stoked at the sight of it, explaining that it's a bag of olestra chips from my time. The gag ends with Fry's robot coworker Bender eating some of the chips and immediately crapping out a brick, which is followed by another brick and then a rapid succession of bricks. A year later, in the romantic comedy The Sweetest Thing, stars Jason Bateman and Thomas Jane, used olestra for some character bonding. As Bateman tosses some of the fat-free chips in his mouth, Jane warns him, "Those are those fat-free chips that cause anal leakage." "You cause anal leakage," Bateman fires back between bites of chips. "It says so on the bag," Jane informs him. Bateman checks the label, then spits out the chips. What kind of marketing brainiac puts anal leakage on this product? How can they even sell that crap? But sketch comedy show Mad TV probably went the furthest when it dropped a fake ad for a new fake fat they called Cholestra. The even newer fat substitute promised its consumers 10% less anal leakage. That's it. That's the whole joke. The skit lasts for 3 minutes, and it's just lots of different ways to offer customers 10% less anal leakage. Meanwhile, complaints from consumers in Indianapolis grew in number and were gathered by watchdog groups like the Center for Science and the Public Interest, who later published a scathing report on olestra. CSPI pushed for the FDA to ban the product, but the FDA thought the warning label for loose stools was enough. All these years later, the question at the center of this fat-free maelstrom remains: how did a chip that causes anal leakage ever get so far to begin with? Frank Nemec, a gastroenterologist in Las Vegas, remembers being interviewed on TV when olestra first came out, and to this day, the lab-created fat substitute still makes no sense to him. It just sounded so ludicrous, Nemec recalls. The idea that you take anything voluntarily so that you do not absorb fat. For him, the risks were as obvious as they were serious. I was concerned that there would be malabsorption, specifically of the fatty soluble vitamins A, D, E, and K, because we know that typically occurs in other instances, such as steatorrhea, which causes conditions like the anal leakage problem that people get with olestra. P&G had spent $200 million over 25 years to develop olestra. So they fought hard for their product. This is something people really want. Anal leakage, Chris Hassel, a senior scientist with P&G, said at the time. Consumer testing tells us that they're all very excited about the idea of snack foods which deliver the full fat taste but don't have any fat in them, even if all the fat ends up in your pants in front of your friends. Nemec has tons of empathy for patients who have faced rectal issues from various medical conditions and takes their issues very seriously. All right, we're not going to read about serious anal issues. I'm skipping that. By contrast, Harvey Anderson, a nutrition science professor at the University of Toronto, who was also a P&G consultant, argued back in the 1990s, if you eat a small serving of olestra potato chips, it will be neither here nor there. He reasoned that the consumer has the power to self-regulate, aided by their ability to tell whether or not they've shit themselves. That really says that. If you overdose, there would be a relatively quick feedback from the old digestive system, he argued. To get olestra approved from the FDA, P&G took a page from the tobacco industry's lobbying playbook per a Harvard University review. Lawmakers from both sides of the aisle who had received money from P&G's Political Action Committee wrote a joint letter in 1995 to the Secretary of Health and Human Services arguing that olestra was safe and should be approved by the FDA. Oh my God, those fuckers. Oh my God. Along those lines, on January 4th, 1996, in anticipation of the pending FDA approval of olestra, Senator John Glenn made the final push from the floor of the Senate, saying that the FDA shouldn't stand in the way of innovation, no matter what that innovation did to the bowels of the country. There was one key holdout, however, Congresswoman Julia Carson, a Democrat who represented a district that covered much of Olestra's test city, Indianapolis. Her constituents had contacted her en masse, complaining of GI problems and asking her to do something about it. Carson planned to press the FDA to add a stronger warning label, one that went beyond mentioning loose stools and instead warned about the serious health effects of fake fat. P&G responded with more lobbying pressure and even called Carson's personal physician in an attempt to change her mind. In the end, it didn't matter. No other congressional leaders joined her opposition, and P&G won. Oh, big surprise. Analyst William Peccariello expressed to the New York Times the general optimism of the investor class and their ballooning belief that olestra was about to change the world. The problem was, as soon as it hit the market, gastroenterologists like Nemec saw a spike in patients with gut problems, and it didn't take long for them to identify the culprit. I had patients that had anal leakage, and I'd go over their diet history, Nemec recalls. If they stopped eating the potato chips with the olestra, they got better. So if there were patients who came in complaining of anal leakage, you'd always go through a diet survey and ask specifically about olestra products. There was another health surprise waiting to be discovered. Although olestra was a fat substitute, the people who ate it still gained weight. The subsequent studies done in the private sector and at universities showed that people eating these fat substitutes did not lose weight, much in the same way that people who drink diet beverages don't lose weight. So they got the anal leakage and the squirts for nothing. 2 years after it was introduced, olestra had failed to win over consumers, with the FDA receiving more than 20,000 consumer complaints. Even after the FDA removed the infamous loose stool warning label, hilariously at P&G's request, customers still weren't interested. Olestra products disappeared from store shelves shortly thereafter, with the fake fat left to be a grease stain on our collective cultural memory. Summed up by two simple words: anal leakage. Or maybe not. In 2009, P&G announced they were now using olestra-like chemicals to make eco-friendly paints and lubricants called CFOS. They built a whole factory to produce this stuff. So I guess it's a good idea, Michael Jacobson, executive director for the Center for Science and the Public Interest, said at the time. As long as you're not lubricating your gastrointestinal tract, it's fine. God, what these companies do to us and what they put in our bodies. It's absolutely disgusting. So don't trust them. That's what I'm saying. Avoid anal leakage, folks. And if you didn't know about that little foray into anal leakage in the 90s through snack chips, I'm glad you were here to hear it. All right, guys. I know that I am behind on today's testimony in the Maya Kowalski trial, and I will come back and do, we'll catch up on that when I can. I got to go to work tonight, though, so I got to get out of here. I got stuff to do. Have a great rest of your day. And let's see. I think I'll leave you with the usual show end today. Make sure that you subscribe to me, meganfox.locals.com. We're doing all sorts of fun stuff over there. Make sure you go and follow me so you get all the notifications. And make sure you hit that like and subscribe if you haven't done it already. I truly appreciate that. And check out my locals page. We're doing fun stuff over there, including Tales from the Restaurant, which are a lot of fun. All right, guys. See you later.
Lost, my world is near its end. I almost felt my head is full of a million choices. I am alive, I'm not here to pretend. I love my friends, my heart is filled with a million voices. Oh, this road has many choices. Oh, and my heart, million voices. Come next to me, my friend, embrace the sky. I'm not afraid to fly. It's not the time to say goodbye. I don't wanna say goodbye. alive, I'm not here to pretend. I love my friends, my heart is filled with a million voices. Oh, this road has many choices, and my heart, million voices. Come next to me, my friend, embrace the sky. I'm not afraid to fly. It's not the time to say goodbye. I don't wanna say goodbye. No, I don't wanna say. No, I don't wanna say goodbye.
So I take it that
Johnny's
you've seen
problem is he
Cameron
should
John's
come
bedroom
storming
before.
in there with
Yeah.
a string of
Do you
garlic
recall whether
and
you
some
went
holy
into
water.
Mr. Judson's
cross.
bedroom? No.
May the
Do you
power of
recall,
Christ
or no,
compel you.
No, I don't.
You
think so.
realized
Miss
his house
Hubbard,
was infested with
except for
succubuses.
that,
And
there's a detail here with you of what it, yes. Do you recall whether it was there when you arrived in the afternoon? I don't remember saying it now. So while she
No wonder he said drown her before you burn her.
Oh my God.
You-
Your next witness?
Now I know
Witness
why
for
you wanted to
known
drown
as
her.
Lasis, and that is
Witness
also
lives in
by
Romania.
video.
Is that correct?
That begins with Miss Vasquez.